Good morning, good afternoon, and good evening to everyone, depending on what part of the world you are attending this webinar called Debates in Andrology First Edition. Please let me introduce myself. My name is Israel Maldonado Rosas from Mexico City, and I am in charge on the organization of this online meeting through the collaboration of the Mexican Academy of Embryology and Andrology and by the Global Andrology Forum. I would like to thank the international societies who supported this webinar, such as the Mexican Academy of Embryology and Andrology, the American Center for Reproductive Medicine, the Red Latinoamericana of Assisted Reproduction, the Global Andrology Forum, the Mexican College of National Urology, and also the American College of Embryology. I would like also thank our international sponsors for supporting our educational program. We are very grateful to you for always demonstrating your commitment to our academic activities. Thank you also to our organizing committee, composed by Dr. Rupin Shah, Professor Hassan Salam, and Ms. Liliana Ramirez. Because without your support and effort organizing the international professors, topics, and taking care of all the details, this meeting would not be possible. And finally, I would like to thank Dr. Agarwal for accepting to be the president of this online webinar and for giving us the opportunity to bring these important debates in andrology to Mexico through a collaboration between the Mexican Academy of Assisted Reproduction and the Global Andrology Forum. I would like to mention that Dr. Agarwal has been ranked as #1 authors in the field of andrology, male infertility, and assisted reproduction. Before asking Dr. Agarwal to continue with the introduction of this webinar, I would like to say some brief words in Spanish, if you all allow me. Muchas gracias a toda la comunidad médica de habla hispana por asistir a este evento que esperamos sea de su total agrado. Now, I will leave the microphone to Dr. Ashok Agarwal to continue with the introduction of this medical event. Thank you very much.
Thank you very much, Dr. Israel. Let me share my presentation. Just a second, and we'll be on the way. Can you see my presentation?
Yes, Dr. Agarwal.
Okay. Well, thank you very much, Israel, my good friend from Mexico City, Israel Maldonado, the famous embryologist and head of SITMER reproductive IVF in many parts of Mexico. And good morning to each and every one of you from more than 100 countries who have joined today in our first edition of the Debates in Andrology. A very good morning. Today is Monday, December 5th, and I am speaking to all of you from Cleveland, Ohio, in the United States of America. It is a great privilege and an honor for me to be the first one to welcome all of you to this special event, which is going to be a historical event, because for the very first time in the history of a virtual meeting in the field of human reproduction infertility, that we have a record number of registered attendees. We have, as of last count, about 2 hours ago, more than 1,400 registered candidates from 100 countries, and this number probably may have increased now. So let me begin by welcoming all of you to this meeting. This is a brief introduction about myself. The most important part of my career or myself is that I am the director of the Global Andrology Forum, which is a group of over 500 clinicians, researchers, and IVF specialists from more than 75 countries. And this has been created about 2 years ago, and I will introduce myself and the Global Andrology Forum more fully towards the end. Let's talk about the meeting today. This is an announcement that we had created about the debateology, and I'm going to talk and walk you through for you to understand what we are going to be presenting today. So we have divided the program into three very important controversial topics which affect almost everyone who's working in the field of reproductive medicine. Whether you are a urologist, an andrologist, an IVF specialist, a gynecologist, an embryologist, or an andrologist, you will all have heard sperm DNA fragmentation.
Recording stopped.
So we are going to hear from our panel of speakers who have been handpicked, and they are all members of the Global Andrology Forum, and they come from 30 countries. We have people who are andrologists. We have specialists from who are IVF specialists, the top IVF specialists in the whole world. Professor Hassan Salam, Dr. Arafa, one of the best andrologists who is from Qatar. And then we have Dr. Israel that you have seen. But this is not enough. We have an expert panel where we are going to have an in-depth discussion led by one of the top urologists and andrologists from Saudi Arabia, Professor Taha Hamoda, and he's going to have a panel of 16 andrologists, urologists, IVF specialists, researchers, and embryologists who are going to ask a variety of questions that really make it difficult for them to fully understand the use of sperm DNA fragmentation in their practice, in their lab, in their clinic, in their research. So this is an opportunity for them to ask the question, and the speakers are going to explain that in live. So we are
recording in progress.
We are going to have this program with recorded part in the beginning, and then the actual live part is the panel discussion. The second part is on TESE for non-azoospermic men. And here again, we have our top expert, Professor Germer Pingera from Austria, then Professor Christine Wins from Belgium. She is an IVF specialist. Then we have Ms. Liliana from Mexico City, and this will be led by our renowned professor from Indonesia, Professor Pongko Wirowo, who just concluded a wonderful meeting in Indonesia, which was about a month ago, where we had almost 1,800 participants from 80 countries. And this was on WHO, World Health Organization, 6th edition. In this meeting today, Professor Pongko is going to lead a discussion on this topic, which is extremely important, with a panel of 16, with so many people that you see and you heard. And these people are extremely smart, very, very well renowned. And it was impossible to get all of this talent together. We were very lucky because these are members of our Global Andrology Forum. So we requested them, and they were very, very gracious to join and be part of this program. And the last one is on varicocele repair in severe oligo-astheno-teratozoospermia, another issue which everyone talks about and or have questions. They are not clear. And this is going to be led by our top andrologist in America, Dr. Amarnath Rambata. And then we will have an ART specialist from Eastern Europe, from the country of Lithuania, Dr. Birut, Professor Birut Zilianti, and then an embryologist from Greece, Dr. Christina. And then this will be led by a discussion panel leader is Professor Florence Boitrel from Paris. And she has a team. She is going to be guiding for the questions and have the speakers provide the answers to the questions, where 16 panel members are there. So this is an exciting program. And our learning objective today is to understand the value of sperm DNA fragmentation in the diagnosis and management of male factor infertility. Second, to highlight the role of testicular sperm extraction in non-azoospermic men, and to explain, lastly, the place of varicocele repair in the current management of men with severe oligo-astheno-teratozoospermia. And this is our standard teaser, which we created from the scratch with a lot of thinking, lot of planning for this program, which we call a Medinar. It's a new concept that we started with the program that started about 2 months ago in Turkey. And this is the third program that we are doing. And you can see the details. It's very difficult to explain all of that. But this is part of the SOP, which went through a lot of iteration, lot of changes before we were able to come out with a program which is really planned to the minute. And this is again the details of that SOP. You can write, we are planning to write a whole paper just to explain about this new concept of Medinar, which is going to change and revolutionize medical education around the world. And this is our team. For sperm DNA fragmentation, you can see we have so many, 20 speakers as well as panelists and panel leaders. And these are all the names and people who are there. And you can recognize many of them maybe from your part of the world, from your country, or from your continent, or from your part of the place where you work. So they come from all parts, 30 countries, and almost 60 speakers that we have here. And this is the second group where we have the speakers, then the panel leaders, and the panel leaders by themselves are extremely smart, very, very well renowned, and it is impossible to get these people to join together. I mean, they are very busy, they are high in demand, and they are speaking all over the world themselves. And this is the varicocele repair in severe oligo-astheno, and you can see again the top people around the world who have agreed to join us here. And this is our step-by-step program that you are going to see today. And this has been broken down into in these three graphics. So what I wanted to announce today, that this is our number of registered. So as they call it here, that the proof is in pudding. So we can all talk, but if you don't have the number, and this is the real number, this is 1,400 registration from 100 countries. You can see all the countries from A to Z that are there. Well, we don't have a Z, we stopped at V. So hopefully there will be some more from those countries. I don't even know all the names until after V. Anyway, this was just updated 2-3 hours ago. So we are very, very happy and honored to have so many of you from so many countries. I would love to visit many of you. I have never been to so many countries. This is the distribution of participants based on profession. You can see we have urologists, the andrologists, the uroandrologists, the residents, the researchers. We have embryologists and so many, even entrepreneurs, people who are in companies or running IVF companies, etc., are joining. And here we talk about the pre-test and post-test, which we have created. We created a multiple choice question from the content of each talk very carefully, and we asked each speaker to submit the best questions from their talk, and after that it went through a very rigorous review and editing and checking of each and every question, and that went on for a couple of weeks until we were able to select the best question, edit them. From 80 questions, we were able to narrow it down to 49, and those questions can be taken as a test before the program starts, and many of you have done that. And then as we finish at 11 o'clock in 3 hours, the post-test will be open, and it will be allowed for about a week for you to take the post-test. Please do that, because it will allow you to reinforce the things that you have learned today. You will also get, besides a certificate of attendance, which you will get after you finish, and you have to go in and fill a questionnaire, and you will be able to get a certificate of attendance. Everyone will get it. And those who do the pre and post test will also earn a special certificate of training, and then you have a chance to win some medical textbook as well. This is a multiple choice question. Pre-test can be taken on this website. After the participant log into their account, this test can be taken from yesterday, or 2 days ago, December 3rd, to today, before the meeting, right before the meeting. And we have 49 questions with 4 possible responses and only 1 correct answer. There is no negative marking, so please do everything. You should complete it before the deadline. For the pre-test, a pre-test is a prerequisite, so you must take the pre-test to take the post-test after the webinar. So this is important. And then furthermore, post-test can be again taken on the website. Post-test will open at the end of this session that we will finish at 11 o'clock. Those who pass the post-test with a score of over 75% will be given a certificate of training, which is really beautiful. The results should be submitted before the deadline. Even our faculty can earn that if they want. And these are some of the books that Dr. Israel plans to award those who have the highest score that they do on the first attempt on the post-test. You can take the post-test many times, but for the purposes of winning, you will have to have your first score is the only one which will be taken into consideration. So what are the benefits? Well, it is free. The program is completely free. You would pay hundreds of dollars, at least in the United States, to have a program like this. You get the book. You have the discussion on some of the cutting edge topics in the field of reproductive medicine for the first time together in a new format, and earn an instant certificate of attendance, fill in a post-webinar survey, and earn a certificate of training as well. So this is all my introduction, and I'll come back towards the end to talk about some of the things about the Global Andrology Forum. I wish all of you a great program. I wish great program to all our speakers and faculty who are there. So I hand it over back to Dr. Israel to begin the program. You are muted.
Thank you very much. We are going to continue with the program. Please, next one.
Hello, everybody. First of all, I need to thank the organizing committee for a very well-prepared meeting and for inviting me to be among colleagues and friends to present the andrologist's point of view regarding how to select patients for sperm DNA fragmentation testing. First, we have to ask ourselves, is semen analysis enough? We all know that semen analysis is the cornerstone to predict male fertility potential, and it gives us an idea about the functional status of the seminal ducts. However, it is subjective. The reference values do not always predict fertility. It can be confusing, especially when dealing with morphology or assessing motility. And the results may be variable depending on inter and intra-laboratory variations and even intra-individual biological variations. This is why we're searching for another biomarker as the sperm DNA fragmentation. But first, let's see the unique structure of the sperm chromatin, where the histones are replaced by protamines, giving the sperm the ability to have a compacted sperm chromatin in the head, which acts as a blueprint for sperm function later on. However, the sperm chromatin is liable to defects, collectively known as sperm DNA fragmentation, which can be single or double-stranded DNA breaks, base deletion or modification, inter or intra-strand cross-linkages. This can be caused by a number of intrinsic and extrinsic factors. Collectively, they are circling around the oxidative stress. Exposure to varicocele, drugs, smoking, radiation can lead to oxidative stress, which will secondarily lead to sperm DNA fragmentation and the deleterious effect on the fertility and even on the outcome of assisted reproductive techniques. Coming to the indication for sperm DNA fragmentation testing, the first will be idiopathic and unexplained male infertility. As for idiopathic male infertility, the studies have shown that there is a significant inverse correlation between sperm DNA fragmentation and sperm count, motility, as well as normal morphology. Other studies have shown that men with idiopathic male infertility tend to have significantly higher sperm DNA fragmentation than normal fertile men. Coming to unexplained infertility, studies have shown that around 20% of men with unexplained infertility have high DNA fragmentation, so they are not unexplained anymore. The second indication will be our famous varicocele. A recent cross-sectional study have shown that men with varicocele have significantly increased percentage of seminal sperm DNA fragmentation, abnormal chromatin packaging, and abnormal mitochondrial membrane potential compared to men without varicocele. These effects can be reversed by varicocele repair. Similarly, another meta-analysis and review article have found the same findings. The third indication will be before intrauterine insemination. A meta-analysis in 2019 have confirmed that men with high sperm DNA fragmentation are associated with significantly lower pregnancy and delivery rates when utilizing IUI. Another study, meta-analysis in 2020, have shown that in cases with low sperm DNA fragmentation are associated with better pregnancy rate with IUI. Coming to IVF and ICSI, also sperm DNA fragmentation testing is very significant here, as when coming to IVF, 4 meta-analyses have confirmed that men with high sperm DNA fragmentation are associated with lower pregnancy rate with conventional IVF. However, when coming to ICSI, only 1 meta-analysis confirmed this significant deleterious effect. However, the 3 other meta-analyses didn't find a significant association. But coming to the live birth rate with ICSI and IVF, 1 meta-analysis in 2015 have confirmed a significantly lower live birth rate with high sperm DNA fragmentation using both IVF and ICSI. Similarly, 2 meta-analyses have confirmed that with high SDF, the women are at greater risk of miscarriage following IVF and ICSI. There are a lot of risk factors that can lead to increased oxidative stress when men are exposed to physical agents like radiation and heat, chemical agents like cigarette smoking, airborne pollutants, drugs, or biological factors like sexually transmitted diseases, increased body mass index, increased male age, or medical comorbidities. With increased oxidative stress, there is increased risk of sperm DNA fragmentation, so it is warranted to test here for sperm DNA fragmentation. The last indication can be before sperm DNA sperm cryopreservation. It is known that sperm DNA fragmentation rates in men with cancer are as high as or even more than infertile men. And it is also known that the cryopreservation process itself can lead to increase of sperm reactive oxygen species production and excessive oxidative stress leading to more sperm DNA fragmentation. So coming to the international guidelines for indication for DNA fragmentation testing. As for the European Association of Virology, they strongly recommended testing DNA fragmentation in men with unexplained infertility. They also recommended doing varicocelectomy based only on high DNA fragmentation in otherwise unexplained infertility, but the recommendation was weak. They evaluated the risk factors for DNA fragmentation, but they put no recommendation for testing in these cases. The European Academy of Andrology recommended, with a low level of quality of evidence, doing sperm DNA fragmentation in addition to semen analysis in couples who are planning to go for assisted reproductive techniques, to weigh between going for assisted reproductive techniques or continuing for spontaneous pregnancy, and to do the test before any assisted reproductive technique. Surprisingly, ASRM, AUA, ESHRI, and WHO said no specific recommendation for indications for sperm DNA fragmentation testing. Foreseeing this drawback in the literature, 2 research groups, the first one was led by Dr. Ashok Agarwal and the other one by Dr. Sandro Esteves, they made a clinical guidelines for sperm DNA fragmentation. Both of them recommended doing the test in men with unexplained or idiopathic male infertility with a grade of recommendation B to C, before IUI or IVF with a grade of recommendation B to C, and after a repeated failure of both of them. As for ICSI, Dr. Agarwal recommended doing sperm DNA fragmentation only with repeated failure with a grade of recommendation B to C, while Dr. Esteves said that it can be also done before the first ICSI with a grade of recommendation B to C. Both of them said that with clinical varicocele, it's recommended with grade C. With risk factors, it's recommended to do the test with grade C. And for sperm cryopreservation, only Dr. Esteves' group recommended doing the test before cryopreservation with a grade of recommendation of D. These grades of recommendation are based on the Oxford Center for Evidence-Based Medicine grades of recommendation. So the take-home message is, sperm DNA fragmentation testing is indicated in men with idiopathic and unexplained male infertility, men with varicocele, IUI before IUI, IVF or ICSI, men who are having risk factor for oxidative stress, and before sperm cryopreservation. Thank you very much.
Ladies and gentlemen, I want to start by thanking Professor Agarwal and Dr. Maldonado for extending this invitation to me. My contribution today is when do I advise SDF testing and why? And let me remind you that during its journey, the sperm needs to replace the histone with protamines, which are more compact, in order to withstand its difficult journey towards fertilization. However, during this journey, the sperm DNA can be subjected to many factors that increase its fragmentation, particularly oxidative stress, as shown in this work by Professor Agarwal. Therefore, there are DNA fragmentation tests. We know them all. So my contribution is, when do I advise them? So when do I advise these tests? Well, as an infertility specialist, I would advise them in three main indications: repeated implantation failure, repeated miscarriages, and unexplained infertility. But what is repeated implantation failure? There is no universal definition. This is the paper we published in 2014 arguing about the need of a universal definition. Because originally the definition was 3 fresh IVF treatment cycles that fail. Then Margoliouth said, well, we need to specify that there are good embryos. Then Stern said, well, it doesn't matter how many cycles. The idea is to transfer 10 or more embryos. And then came our paper arguing that the age of the woman is also important. However, regardless of our definition, is sperm fragmentation related to the result of assisted production? And the short answer is yes. From this meta-analysis by Zeni and Sigmund, as you can see, there is a relation between sperm DNA fragmentation and pregnancy, particularly after IVF. Not very clear with ICSI, but as we know, in ICSI, we choose the sperm. Simon also produced this work in 2014, showing again that the comet test and the tunnel test are good predictors of fertilization of pregnancy in assisted production. And this is the meta-analysis of Simon Italia published in 2017, again showing the definite relationship between SDF and pregnancy in IVF. So what do we do in these cases? Oral antioxidants, varicocele ligation, frequent ejaculation as advised by some people, sperm selection by magnetic cell sorting or IMSI, and finally, if we are doing ICSI with ejaculated sperm, maybe we should do it with testicular sperm. And this is the work of Professor Recai Papucu from Ankara in Turkey, showing that yes, if you do this, you have a better clinical pregnancy rate and a better ongoing pregnancy rate. The second indication is repeated miscarriages. But again, what is recurrent miscarriage or repeated miscarriage? The definition is not universal. The Royal College says that 3 miscarriages, consecutive miscarriages before 24 weeks. ASHRI says 2 miscarriages before 24 weeks. But the American College says 2 miscarriages before 20 weeks, because in America, the cutoff point between miscarriage and preterm labor is 20 weeks. The incidence is about 1%, and this is more than what you would expect. Miscarriage is also more common as age increases. There are many reasons for recurrent miscarriage, as you can see from this diagram, but in about 50% of cases, the cause is unknown. It could be chromosomes, as you can see from this work of Carmen Rubio of the BV group. Yes, the incidence of chromosomal anomalies in the embryos is increased in patients with recurrent miscarriage. But what is more important are sperm anomalies, as you can see from this work of Rosenbuch and Sterzik, and also from Carmen Rubio. And here is a paper from Ankara, Italia, showing that yes, sperm DNA fragmentation is more common in recurrent miscarriages. As you can see here, this is the recurrent miscarriage group on the left side, and this is the control group, and things are more, as you can see by the two different sperm DNA fragmentation tests, the tunnel test and the SCSA assay. And again, this is the meta-analysis by YIFO, Italia, showing yes, if you use any SDA fragmentation test, as you can see here, you have a higher incidence of DNA fragmentation in couples with unexplained recurrent miscarriages. And again, a more recent meta-analysis from China, from DAI Italia, showing the same result. And again, showing that this is even more pronounced if you use the halo test. So what we do in these patients, again, oral anticoagulants, varicocele ligation if it's not done, frequent ejaculation as some people advise, and then ICSI and trying to choose the right sperm. The third indication is unexplained infertility. But again, what is unexplained infertility? Everybody agrees that this couple must have a normal semen fluid analysis, proper ovulation, and healthy patent tubes. But I would argue that also the cervix must be working properly. Because in this unexplained infertility, there must be a cause which we don't know. And people have been looking for a cause in the cervical mucus, negative postcoital test, luteal and rupture follicle syndrome, luteal phase defects, minimal endometriosis. But one of the causes may be defective or imperfect fertilization, like fertilization failure, partial or. So, is it really prevalent in unexplained? Is DNA fragmentation more prevalent in unexplained infertility? And short answer is yes. This is a paper from Malmö in Sweden, and as you can see, the incidence of people having fragmentation more than 30% was 8.4 in their group, and more than 20% was about 26% in their group. And even if you do ICSI for these couples with unexplained infertility, again you find that the cumulative pregnancy rate, the miscarriage is higher the more you fragmentation you have, and the miscarriage rate is higher, and the cumulative pregnancy rate is lower. And again, if this is if you take fresh and frozen cycles, and if you look at fresh cycles also, the things are even more pronounced. The implantation rate is lower, clinical pregnancy rate lower, and live birth rate lower, as you can see from this paper published recently. So again, what you do, oral anticoagulants, frequent ejaculations. What I would do for this couple of unexplained infertility, 2 cycles of IUI. If not, then you go for ICSI, and for this we try to choose our sperm. So in conclusions, ladies and gentlemen, an intact sperm DNA is necessary for proper fertilization. As an infertility specialist, I would advise STF testing in recurrent implantation failure, repeated miscarriages, and unexplained infertility. If the test is positive, antioxidant may be prescribed with proper monitoring before resorting to assisted reproduction. And in this case, we should choose our best embryo, best spermatozoa by one of our methods. And finally, if this does not work properly, we should remember that testicular sperm may be better than ejaculated sperm in these cases. And with this, I come to the end of my presentation, and I would like to thank you very much.
Good morning, everyone. I would like to thank the organizing committee for giving me this opportunity to present this talk today. My today's topic is the management of elevated sperm DNA fragmentation in the IVF laboratory. According to the learning objectives we are going to cover today, we are going to describe the recommended strategies found in literature to manage sperm sample with DNA damage during sperm preparation and prior to an IVF procedure, understanding the capacity of healthy oocytes to repair sperm DNA fragmentation. We are going to briefly describe on the use of sperm retrieved by testicular biopsy to improve clinical outcomes. We are going to discuss the conventional methods of sperm selection,
we're going to describe briefly the ability of the most important sperm selection techniques commonly used during ICSI process to select sperm with intact DNA and currently considered as add-ons such as IMSI and PIXI, and some others such as MAX. About the impact of sperm DNA fragmentation in IVF outcomes, Dr. Agarwala 2020 reported that elevated levels of sperm DNA fragmentation affect fertilization, embryo development, pregnancy, miscarriage, and live rates, also health and well-being of offspring. According to Dr. Messiger and Dr. Andrology 2019, they reported that the use of high-quality oocytes from donors and sometimes from patients may offset the negative impact of sperm DNA fragmentation in clinical outcomes. This one is because the capacity of these high-quality oocytes to repair DNA of sperm. About the sperm preparation techniques we commonly use in our IVF laboratory, we have two, swim up and density gradients. Both of them have the same capacity to lower the sperm population with DNA damaged after sperm preparation. We have some new trends to perform the sperm preparation techniques, such as this kind of dishes that with a membrane, by swim up, they are going to separate the sperm population without centrifugation. But those results should be confirmed. About the clinical outcomes from elevated sperm DNA fragmentation in conventional IVF or ICSI procedures, I can say that there are some articles in literature like this I am showing you. This is a systematic review and meta-analysis published in 2021 by Dr. Rivas. And they found that when they perform conventional IVF in elevated sperm DNA fragmentation and compared to low levels of sperm DNA fragmentation population, the implantation, pregnancy rate, and live rate were significantly lower. But when they perform ICSI, as you can see in the blue square, the implantation, pregnancy rate, and live rate remained lower compared to the low levels of sperm DNA fragmentation population, but those results are not significant. They conclude that adverse effect of elevated levels of sperm DNA fragmentation on IRT outcomes seem to be higher in conventional IVF than ICSI cycles. ICSI should be the preferred technique for oocyte insemination in cases of elevated levels of DNA fragmentation. About the recommendation found in literature to manage semen samples with elevated levels of DNA fragmentation to avoid subjecting the sperm cells to prolonged culture before an IVF can be a good alternative. The insemination should be performed few hours after ejaculation. Short ejaculate abstinence, repeated ejaculations, and density gradient sperm preparation are required to reduce sperm with DNA damage, ranging from 22% to 47% compared to swim-off technique, showing a reduction of only 35%. But when it's appropriate to use an add-on, according to the Human Fertilization and Embryology Authority, has rated in red the sperm selection techniques such as PIXI and IMSI due to the lack of randomized controlled trials to demonstrate an improvement on live rate in the general population. But they consider that some add-ons may be offered for reasons other than to increase the chances of having a live birth. In some circumstances, there may be a justifiable medical reason for using it as part of fertility treatment, especially when no risk has been reported to the patient or children by the use of these techniques. So about the benefits we can by the using of sperm selection techniques, Dr. Bradley reported at 2016, that the live rate with testicular sperm is 49.8%, using IMSI 28.7%, and PIXI 38.3%, compared to non-intervention such as ICSI with only 24.2%. So they concluded that PIXI has shown to be more benefit for elevated levels of sperm DNA fragmentation than IMSI, and testicular sperm appears to be the best alternative among others. According to Dr. Hassansen in 2020, they reported that PIXI and MAX are efficient techniques to select sperm in cases with elevated levels of sperm DNA fragmentation. However, MAX are preferred when the females are younger than 30 years old, and PIXI should be chosen for couples with older female partners. For take-home messages, I can see that ICSI instead of conventional IVF may be a better alternative to improve clinical results in cases with elevated levels of sperm DNA fragmentation. The testicular biopsy could represent the best option for elevated levels of sperm DNA fragmentation, but it still remains controversial. There is encouraging evidence that applying the following add-ons such as PIXI and MAX for sperm selection in elevated levels of DNA fragmentation could improve the clinical outcomes. A combination of these techniques should be investigated more, such as PIXI, MAX, testicular biopsy, short and repeated ejaculations. It is important to assess the DNA fragmentation before an IVF treatment to choose either conventional IVF or ICSI to improve clinical outcomes in order to reduce the number of IVF attempts to get a live birth. Thank you very much.
Good morning, good afternoon, and good night, everyone, wherever you are. I am Professor Taha Hamouda, uro-andrologist from Egypt, and I'm the panel leader for this first session on sperm DNA fragmentation. In our session, the SDF was presented in a unique, comprehensive, and multidisciplinary fashion from 3 different expert perspectives of andrologist, IVF specialist, and embryologist. So I would like to thank all the speakers. Your great talks will definitely induce a lot of panel discussions. I will invite all the panelists to express their comments or questions. Then I will ask the speakers to respond to all inquiries. So we will start with Dr. Yannick Kontz from Austria. Dr. Yannick.
Thank you very much for the great presentations. As a clinical andrologist, I'm interested in precise clinical treatment options on elevated SDF prior to ICSI. Since SDF is, among other reasons, caused due to oxidative stress and inflammatory processes can increase SDF. As mentioned in the previous presentations, oral antioxidants are a valuable treatment option. But my question is, do you consider empiric use of non-steroidal anti-inflammatory drugs in certain patients? And do you test for bacterial contamination, infection of semen, e.g. ejaculate culture in patients with high SDF?
Thank you, Dr. Yannick. Now we'll move to Dr. Tomer Avidor-Rees from the USA. Dr. Tomer, Professor Tomer.
Hi, everybody. Great conference until now. I am Tomer Avidor-Rees from the USA. My question is regarding in the case of DNA fragmentation. When we have high sperm DNA fragmentation index, it is recommended to be recognized that the couple have unexplained infertility. When they have unexplained fertility, it suggests that the presence of a male factor. So high DNA fragmentation is a male factor. My question is, does an intermediate sperm DNA fragmentation index still also indicate the presence of a sperm factor? And then a second related point, since DNA fragmentation test examine different aspects of DNA fragmentation, the next question is, should we use more than one type of DNA fragmentation test, for example, SCA versus comment, in our diagnostic of unexplained fertility? Thank you.
Thank you very much, Professor Avidor-Rees. And now we'll move to Dr. Nadia Kazdar from France. Dr. Nadia.
Still
Hi.
Prior to ICSI. Since SDF is, among other reasons, caused due to oxidative stress and inflammatory processes.
I am Dr. Kazdar Nadia. I am an embryologist in Paris. Thank you all for your presentation. I have 2 questions. What do you think about microfluidic for the selection of spermatozoa with low fragmentation rates? And my second question, what is the ideal duration of an antioxidant treatment? And in cases of IVF failure with high rates of DNA fragmentation, do you recommend the testicular biopsy? Thank you.
Thank you very much, Dr. Nadia. Dr. Fotios Dimitriadis from Greece. This is your turn, Dr. Fotios.
Hello, everybody. I want to thank the speakers for the excellent lectures. I have one question for Dr. Salam and Dr. Maldonado. Well, several methods of sperm selection have been used to select spermatozoa with minimum DNA damage for ART purposes. From the clinical point of view, which method do you think gathers the most advantages up to date? And to Dr. Arafa, excellent speech. Thank you very much, Dr. Arafa. In cancer patients, after chemo and or radiotherapy, do you suggest any reliable strategy to characterize sperm chromatin quality and at the time of sperm banking, for example, flow cytometry based chromomycin A3 or other assays? Thank you very much.
Thank you very much, Dr. Fotios. Dr. Vilvabalsi Karthikeyan from India. Dr. Karthikeyan.
Yes, thank you. So I have two questions here to Prof. Salam. Number one, is there a role for genetics in men with elevated DNA fragmentation, specifically when they don't respond to medical therapy, and in those men with idiopathic infertility? So what is the role of genetics in this situation? Second question to you, sir. Is it possible to perform DNA fragmentation on a testicular sperm, which is retrieved surgically, in a man with genetic or idiopathic etiology? And what are its implications? Because in this process, the testicular sperm will have reduced DNA fragmentation? Is it possible to find it out? Thank you.
Thank you very much, Dr. Karthikeyan. Now we will move to Indonesia to hear the question or comment of Dr. Fikri Rizaldi. Dr. Fikri.
Thank you, Professor Ta. Thank you, Professor Agarwal, Dr. Rupinsa, and Mexican Academy of Embryology and Andrology for this opportunity. I have a question for Professor Arafa and Professor Hassan Salam. What is your recommendation for high sperm DNA fragmentation patients with clinical varicocele? Do you routinely give antioxidants or surgery only for these patients? And if you prescribe antioxidant, how long and what time is the best time? Is it before or after surgery? Thank you, Professor.
Thank you very much, Dr. Fikri. Now back to India, to Dr. Pallavi Saini. Dr. Saini.
Namaste everyone, I am Pallavi Saini from India. As discussed in the presentation by Dr. Maldonado, oocyte has the capacity to repair sperm DNA fragmentation. So my question is, how does healthy oocyte help in improving SDF? And if it is so, can we give antioxidants or any supplements to the female partner to improve their oocyte or overall health, which will indirectly improve the SDF? Thank you.
Thank you very much, Dr. Saini. Very smart question. We'll move to Dr. Giorgio Ivan Rosso from Italy. Dr. Giorgio.
Hello to everyone. I'm andrologist, a urology, and expert in reproductive infertility. So I will give the questions to Dr. Salam. Are there any evidences that treatment with FSH can ameliorate sperm DNA fragmentation in patients with unexplained infertility? Because up to now, we don't have enough evidences to repair or to ameliorate sperm DNA fragmentation. And my last question is, are there evidences about the relationship between telomerase length and sperm DNA fragmentation? Because we know that by the increasing of age of our patients, the rate of sperm DNA fragmentation can increase, but we don't know if there is an impact or relationship with telomerase length of chromosome. Thank you so much.
Thank you very much, Dr. Rosso. And Dr. Munir Jamali from Morocco. This is your turn, Dr. Munir.
Hello, my name is Dr. Amari, urologist from Morocco. I would like to thank Professor Salam for his presentation concerning the indication of STF testing. And I would like to ask him a question concerning the antioxidant treatment recommended when the latter is positive. There's a lot of antioxidant therapeutic formulas with different components in different doses. In your experience, is there a specific combination of antioxidants that is more effective than others, and at what doses? My second question concerns the monitoring of the treatment before ERT. How often should it be done before the patient is deemed fit to donate sperm of optimal quality for fertilization? Thank you.
Thank you very much, Dr. Jabali. Dr. Sandrine Tamayo from Italy.
Hello, everybody. Thank you for this invitation. I have two questions. One for Professor Arafat. As an embryologist, I would like to know how close should be the time of in vitro treatment, how close should be the time between in vitro treatment and to perform a SDF test. If we should ask an SDF test very close to the IVF treatment, or even if we can do it with a longer time. And as an embryologist also, I will have to make this hypothesis. If we do a sperm DNA fragmentation close or on the same day of IVF or ICSI treatment, do you recommend to continue embryo culture until blastocyst stage, or to perform a pre-implantation genetic diagnostic testing for aneuploidy? Thank you.
Thank you very much, Dr. Caballo. And now we move to Dr. Nirvika Sharma from the USA. Dr. Sharma.
Hello, everyone. Great presentations. Thank you. My first question is to Professor Salam. You discussed the use of sperm selection methods such as magnetic cell sorting or MC for management of ART failure in patients with high SDF. What are your thoughts on using artificial intelligence to sort and select the best sperm for ICSI? Do you think that AI can help select sperm with low DFI? The second question is for Dr. Maldonado. The research is currently being done to understand the epigenetics in sperm, which is the control of DNA and gene expression that is independent of DNA sequence itself. What are your thoughts on studying the DNA methylation pattern in sperm to see stable versus unstable methylation? Can this become an add-on with SDF testing in future? Thank you.
Dr. Sharma, thank you very much. And now we'll move to Professor Zeskin Yunis from Turkey.
Thank you, Dr. Taha. Thank you, Dr. Taha. First of all, I want to thank for the great presentations. And I have two questions. The first one is to Dr. Salam. Which type of antioxidant therapies did he recommend to patients with different levels of sperm DNA fragmentation? And my second question is to Dr. Maldonado. Do you recommend antioxidant therapy in patients with high SDF before sperm testicular extraction or ICSI? Thank you.
Dr. Zeskin Yunis, thank you very much. And now we move to Dr. Evangelini Evgeni from Greece. Dr. Evgeni.
Hello, everybody. Thank you very much for the excellent presentations. I have three questions, one for each speaker. To start with Professor Salam, if testicular biopsy is considered as an option of high SDF management pre-ART in unexplained infertility, which method of sperm retrieval would you opt for? And does micro-TESE seem more promising than TESE? The second question is for Professor Maldonado. As ICSI is mentioned as the preferred method for SDF management in ART, are there any concerns for offspring health? And also, is the technique of microfluidics indicated as an alternative for efficient sperm selection? The last question is to Professor Arafat. What is the designated time frame for SDF testing before the effectuation of ART? And should SDF testing be repeated in two different samples, and at which time distance? Thank you very much.
Thank you very much, Dr. Evgeni. And now to Tunisia with Dr. Salima Dawood.
Thank you, Dr. Hamouda. Greetings from Tunisia. So my first question is for Dr. Salam. You proposed a list of solutions in case of high SDF ranging from the simplest, such as oral antioxidants, to the most complex, such as using testicular sperm. Considering the invasive character and the cost of testicular biopsy, in what specific cases would you recommend using this option? My second question is to Dr. Maldonado. It has been demonstrated that several patients fluctuate in their SDF values. Given this fact, is it reasonable to consider second SDF testing in the case of high SDF or in case of low SDF with suggestive context or systematically for other patients? Thank you.
Thank you very much, Dr. Dawood. We'll move to Dr. Shadi Yazbek from France. Dr. Shadi.
Yes, thank you very much for your excellent presentations and clear presentations. My question is to Professor Salam. What is the consistency of repeated sperm DNA fragmentation measurements regarding the technique and the cutoffs? Does it depend on the technique, SCSA, tunnel, or comet? Should the cutoffs differ? And what is the added value of high DNA sustainability measurements which reflects sperm chromatin compaction? And the other question to Dr. Maldonado, as an IVF specialist undertaking a treatment in the case of unexplained infertility and several previous IUI failures with high SDF, what is the risk of fertilization failure in conventional IVF, and would you recommend ICSI or IMSI or even PICSI as a first attention treatment? Thank you.
Thank you so much, Dr. Yazbek. And now the last question comes from Vietnam with Dr. Nguyen Phuoc. Dr. Nguyen, please.
Thank you very much for a great presentation. I have questions to Professor Mohamed Arafat. There are questions about the different cutoff thresholds in the analysis of SDF results. For example, 30% or 25% and others. What threshold are you using and why? And another question is, if SDF still does not improve after the treatment, what will you do? Thank you very much.
Thank you very much, Dr. Phuoc. And now I would like to thank all the panelists for their very interesting questions and comments. And I would like to ask the speakers to respond to the panelists' queries. We should start with the same order with Professor Mohamed Arafat. Professor Arafat.
Thank you very much, Dr. Taha. And I want to thank all the panel for the very interesting and nice questions. I'll try to answer as much as possible due to the time constraint. For Dr. Kunz's question, actually, there are no guidelines for the use of non-steroidal anti-inflammatory drugs in male infertility. In case of sperm DNA fragmentation, the pathophysiology that inflammation can cause DNA fragmentation is through the increase of reactive oxygen species. When this comes to the extent exceeding the reducing potential of the testis and the epididymis, then there will be oxidative stress and sperm DNA fragmentation. So the pathophysiology here is, again, oxidative stress and not inflammation. So in these cases, we recommend antioxidants and not NSAIDs. And no, we don't search for bacterial contamination or do culture in cases with high DNA fragmentation. However, in cases with pyospermia, we order sperm DNA fragmentation. And in our lab, routinely, we do semen analysis with peroxidase test to check for pus cells when doing the sperm DNA fragmentation. Coming to Dr. Avidor Rees's question, I believe high sperm DNA fragmentation may indicate male factor, whether it is high or intermediate, with varying degrees, because there is an association but not a constant relation with it. Using two methodologies for testing sperm DNA fragmentation is a very nice idea. There is no guideline for it, and I believe it is worth studying in a prospective study that we can maybe do together. As for Dr. Dimitriadis' question, in cancer patients, we do the cryopreservation prior to the chemotherapy and radiotherapy. Due to the time constraint, because of the very short window before beginning the treatment, we usually don't have the time to do the sperm DNA fragmentation. In our practice, what we do is I tell the patient to give frequent ejaculations, frequent samples. So I will gain the benefit from repeated ejaculation on lowering the sperm DNA fragmentation in these patients to get the best samples for cryopreservation before chemotherapy. After chemotherapy, by 2 years, we go for sperm DNA fragmentation testing before getting the patient to have a spontaneous pregnancy or looking for fertility. For Dr. Rizaldi's question regarding the use of antioxidant therapy with patients with varicocele repair, our recent meta-analysis from the GAF group has proven that, has shown that antioxidants have improved semen parameters, including concentration, total, and progressive motility, independent of the varicocele repair itself. So I believe it is indicated to give antioxidants with varicocele repair. In my experience, what I do is patient with high DNA fragmentation, even with varicocele, I will start with antioxidants for 3 months. If no improvement, I will go for the operation, and I will continue giving the antioxidants for another 3 to 6 months following the surgery. For Dr. Kamayo and Dr. Evgenie's question, there are no guidelines regarding the timeline between, or the time frame between the DNA test and the IVF. However, we do it as early as possible when it is indicated. So if we find it, we can treat it. But if we are going to recommend it before IVF, I believe the sooner the better, because as you know, DNA fragmentation occurs mainly in the epididymis. So it doesn't need to wait for the 3 months for the spermatogenic cycle. So the nearer the better to the IVF cycle, we can recommend DNA fragmentation. And should we repeat DNA fragmentation twice as the semen? I think this is another thing that should be investigated, because there are no guidelines for it. For Dr. Fo's question, we are using the 30% cutoff value for the sperm chromatin dispersion, because this is the most known for the halosperm kit, and this is the one recommended by the company itself. However, if the DNA fragmentation is not improved with treatment, as said in the presentations, we'll go for ICSI using ejaculated sperm and sperm selection techniques. If not, with repeated failure, in our practice, we go with testicular sperm. I hope this was clear, and thank you very much.
Thank you very much, Professor Arafa, for your clear and detailed response. Professor Hassan Salam, the time is yours.
Thank you very much, Professor Hamouda. Thank you very much for all the speakers and the panelists, of course, who have asked for many questions for me specifically. Actually, many of these questions are points of research, because many of them do not have answers at the present time. We had a question from Greece, for example, which is the best method to select the sperms if we're going to, in cases with high DNA fragmentation. I don't think there is any answer for this. I would go for IMSI, because it's the technology available to us, and that we can use. But actually, I would like to refer this question to Dr. Maldonado, because it's really more concerned with the people with the lab. They would tell us which, in their reasoning, is the best. The second question coming from India is about the role of genetics. Of course, the genetics play a very important role in male infertility in general. So again, yes, is there a role of genetics? Yes, there is a role. Do we refer our patients regularly to a geneticist? Not really, but in cases of repeated failures, for example, we will refer them to a geneticist, because again, as said, is there a relation between the telomere length and then DNA fragmentation? I don't know if there is any. It is a point of research, as I say, and it is very interesting and very intelligent question, and I think there is a need to do some research to do this. Again, regarding DNA with testicular biopsy, well, I would do this in cases of repeated failure, as Dr. Arafa just said. I mean, the first thing is to do if we have DNA fragmentation, then okay, we will do ICSI. We will do ICSI first by ejaculated sperm, trying to select the first sperm as we think from a morphological point of view. But of course, if this fails, then we will go for testicular biopsy. In which method should we take the sperms with? Again, I don't think there is any work that has been done in this respect. It It is again a very interesting point for research. I will leave it to the andrologists, our colleagues, the andrologists. Maybe they will tell us which method. Of course, we would go first for the simplest method. If there are sperms there, then we would go for a needle. But if again, if there is a repeated failure, maybe we go for open biopsy. But again, I would leave the decision to our colleagues, the andrologists. There was again another question about the effect of FSH in DNA fragmentation. Again, I don't think there is any public, concrete answer for this. But again, I would value your experience, Dr. Taha, Dr. Hamouda, about this. It's really, as a senior expert andrologist, of course, you can maybe tell us if there is, if you think that in your assessment, if FSH can help in this increased DNA fragmentation. And again, there was another question about antioxidants. Which antioxidant? Again, I think that there are many research reports on antioxidants for people with DNA fragmentation, but there is no comparison between different antioxidants. So what we do actually in Egypt, at least, we have a preparation which is advanced or whatever. It is a combination of many antioxidants, and as said by Professor Mohammed Arafah before, we would go for 3 months and then try, of course, to measure oxidative stress, because this is the most important factor in DNA fragmentation. So we do this, we do it with this new simple test introduced by Professor Agarwal, the Myoxis system, and we will do this. And if, because as we know that if we give too much antioxidants, maybe we can reverse things and enter into reductive stress, as shown by the work by our colleague Henkel and Professor Agarwal again. So this is how we will do it. Artificial intelligence, can it help? Of course, artificial intelligence can help, but we are waiting for our colleagues who work with artificial intelligence to tell us which way would they like to go to select the sperm. We, as gynecologists, infertility, IVF experts, we did some work regarding how to select the best embryo to put, and maybe even the best oocyte, although we are not going to discard the oocyte. But again, artificial intelligence must be a very helpful tool, and it is again food for thought and for research. There is also, again, testicular biopsy, which is the best indication for testicular biopsy for DNA fragmentation. In my assessment, it's failed ICSI. I mean, we do ICSI, and if it fails with ejaculated sperm, then yes, we will go for the testicular sperm doing ICSI. And finally, the consistency of DNA fragmentation. Again, I could have information about this, and maybe people like Professor Agarwal or your good self, Professor Hamouda, can tell us if there is a consistent. I don't think there is work on this showing that the test is always the same. There must be some sensitivity and accurate tests to make sure that the test is actually accurate and can be repeated, is repeatable. So these are all excellent questions, but as you can see, they are all food for thought, and they are all very good ideas for future research. And thank you very much.
Thank you very much, Professor Salam, for your expert response. I'm sorry, I hope all the audience has got your answers and your response, because there was a lot of noise and interference And I'm not sure if all the audience got the answers or not. Hopefully, yes.
From my
Now,
side, please, from my side.
now,
From my side.
please, I don't know. I don't know. This is there is a lot of noise now. Yes, now no more noise. Thank you, Professor Salam and Dr. Maldonado. The last word is for you. Dr. Maldonado.
Thank you very much, Dr. Taha. I would like to answer this question. If the question is if oocyte has the capacity to repair sperm DNA fragmentation, how does healthy oocytes help in improving sperm DNA fragmentation? I can say that unlike sperm, mammalian oocytes are equipped with DNA repair machinery and capable of repairing DNA damage due to the DNA damage in gametes induces adverse health effect in the progeny. So efficient DNA repair during gametogenesis and the early embryonic divisions after fertilization is essential to prevent the transmission of the DNA damage to the next generation. But it is well known that the ability of the oocyte to repair sperm DNA fragmentation depends on the extent of the sperm DNA fragmentation and on its cytoplasmic and genomic qualities. In fact, it has been demonstrated previously that oocyte quality conditions the negative impact of sperm DNA fragmentation on pregnancy, because no clinical significance was found when oocytes were donated or donated oocytes were used. And also, for example, although there is a chance of selecting the sperm with non-fragmented DNA when we use ICSI, the higher sperm DNA fragmentation has the higher chance of selecting one sperm with fragmented DNA. But previous studies have demonstrated that human mature oocytes are provided with components from all DNA repair pathways. And also during the first 24 hours of the embryonic development, around the S phase, oocyte DNA damage in both parental genomes, but in some cases, high sperm DNA damage can be not properly repaired by the oocyte, and so the apoptosis can occur. Sometimes the lesion can be tolerated, or sometimes the fertilization can occur, but poor embryo quality or IVF failure can occur. So this is important to take into account during this when we are using donor oocytes. So another question was if the separation techniques about the microfluidics for sperm selection of spermatozoa with low fragmentation rate. I can say that microfluidic sperm sorting technique selects highly motile sperm with lower levels of sperm DNA fragmentation compared to conventional sperm sorting techniques. Although microfluidics sperm sorting technique provides a higher number of top quality blastocysts than conventional methods of sperm separation, such as density gradients. However, neither euploidy nor live rates are improved. So, although more efficient techniques to reduce sperm DNA fragmentation, avoiding centrifugation is very welcome, although I believe that this is not the complete solution. So, to increase the live rates and still have some weaknesses, such as the lower and non-sperm recovered compared of this when you will use this technology compared to the conventional separation technique. Thank you very much.
Thank you very much, Professor Maldonado. And thank you to all speakers. And now we'll come to the time to summarize the three talks of our session. And as we have seen in the presentations, SDF refers to DNA strand breaks in the sperm with defective chromatin compaction, which may have a potential negative role in human reproduction with adverse outcomes, including unexplained and idiopathic infertility, recurrent pregnancy loss, and failure of assisted reproductive techniques. Sperm chromatin compaction is necessary to deliver the intact DNA to the oocyte and is critical for the production of a viable pregnancy. On the other hand, a healthy oocyte may have a role and the ability to repair damaged sperm DNA. There are several underlying molecular mechanisms that can lead to increased SDF and is associated with various exogenous and endogenous risk factors. Particularly, oxidative stress is a common theme that can directly and indirectly lead to sperm DNA fragmentation. Professor Mohammed Arafah has clearly emphasized on how to select patients for SDF testing from the andrologist perspective. Professor Arafah deliberated on when we should test for SDF, and he listed the indications as varicocele prior to ARTs, including IUI, IVF, and ICSI, and with exposure to risk factors, and finally before considering sperm cryopreservation. Dr. Arafah also has summarized various professional societies and the clinical guidelines recommendations for SDF testing. Professor Salam has also provided the IVF specialist overview on when and why we should advise SDF testing. As an infertility specialist dealing with the female partner, Professor Salam advises SDF testing when there is repeated implantation failure, repeated miscarriage, or unexplained infertility. And to manage ART failures and unexplained recurrent miscarriage in cases with high FSH, high SDF, he has advised the use of oral antioxidants, frequent ejaculations, repair of varicocele if there is varicocele, and a sperm selection method. He also advocates the use of testicular sperm with ICSI, as he has shown that testicular sperm demonstrate twofold increase in the clinical pregnancy rates and significantly lower miscarriage rate compared to ejaculated sperm. Finally, Dr. Israel Maldonado, as an embryologist, has elaborated on the management of elevated SDF in the IVF lab. He described different strategies to manage semen samples with high SDF in the IVF lab prior to conducting ART. Dr. Maldonado advised SDF testing before IVF in order to correct or improve SDF, and this will consequently minimize the number of IVF attempts. He detailed and compared the different sperm selection techniques and demonstrated their different outcomes. Again, the use of testicular sperm in ICSI for infertile men with high SDF has been supported in the viewpoint of embryologist Dr. Israel Maldonado. And this is a conclusion of the first session, and we should now move to the second very exciting session on TESE for non-azoospermic men, moderated by Professor Bronco Piro. And thank you to all for your attention.
Dear colleagues of the world attending this webinar, the GIF management team has given me the task to present the topic of TESE in non-azoospermic patients from the perspective of one andrologist. This implies that in the following 7 minutes we will not discuss about men suffering from classical azoospermia. Thus, we will not talk about obstructive or non-obstructive azoospermia. The real interest in a conscientious physician is to treat the condition of male infertility in order to bring the healthy baby into the world. This is the request of a couple suffering from childlessness, and this task must be solved. On the other hand, the current data of 500,000 IVF and ICSI cycles show that the pregnancy rate is nevertheless low, around 30%. So we have to ask ourselves, what we can do better. First and foremost, a throughout patient examination should be performed, including not only a medical history, but including a specific reproductive history, an ejaculation examination, determination of hormone status, and supplementary sonography. Indeed, this algorithm corresponds to a strong recommendation to the current guidelines of the European Society of Urology from the year 21. In addition, special examinations such as genetics, ROS activity determination, and so on should be offered to achieve the best results by TESE. This is definitely important to discuss all therapeutic options with the couple, and I want to stress out, with the man and his women. This recommendation is also anchored in the AOE guidelines with a high recommendation character. Finally, of course, specific national legislation requests must be taken into account by an operating urologist. Unless otherwise, you risk a lawsuit. Therefore, our department has, for example, developed specific SOPs, which are not only to be followed during the operation itself, but rather have to include the treatment beforehand. But be aware, following only some guidelines can lead to misunderstandings and disregard of the latest scientific findings. As an example, I am quoting the good recommendation of the European Academy of Andrology from 2018. At that time, there was no recommendation for any drug therapy with, for example, aromatase inhibitors, while in the current guidelines of the AOA and RSRM, this form of therapy is mentioned very well, at least in the case of testosterone deficiency. So, what can a urologist do before he is sending his patient to the operation room? He must consider results from specific cellular markers in the semen, for example, the findings obtained by direct or indirect methods to assess the sperm DNA integrity, and then the redox potential might determine his decision. He will respect several findings by extracellular markers or cytokines. As well, urologists should discuss genetic examination, which somehow might change his primary procedure. In the last decade, we learned so much from genetic and epigenetic studies, allowing us to counsel patients better. In the following graph, published a few weeks ago, possible causes of altered sperm function are listed. It's up to the urologist to identify these modifiable causes and discuss this with his patient, so that the operative results are becoming better. Let us look at the history of the guidelines. In 2010, the ESHRE guidelines mentioned that infertile patients show increased level of DNA fragmentation. And the EU guidelines in 2018 recognized that such DNA damage might negatively impact the conception rate. Finally, in this year, the meta-analysis of Farku et al. Provided us the evidence that higher sperm defragmentation is detrimental not only for the natural conception, but even for assisted techniques. Surprisingly, the actual guidance by the AOA RSRM from 21 are not recommending the general assessment of sperm defragmentation, see the recommendation 15, except for cases of repeated pregnancy losses, see the recommendation 19. In line with this before mentioned study is the recently published meta-analysis by Jordan Ribas Manu investigating 78 studies and collecting data over 25,000 RT cycles. The author calculated that DNA damage leads to a significant implantation rate reduction by 1/3, and furthermore, the final pregnancy rate was lower for IVF or ICSI cases, although there was a great range in the odds ratio. This inevitably brings us to the following question: can the urologist contribute somehow to improved sperm selection? Well, in order not to span the time frame of this lecture, we can summarize that these listed techniques sound very interesting, but have not been reliably tested for their everyday suitability and might be reserved for specific requests. So, When should one urologist counsel a man to undergo a surgical intervention like a TESE? Even in a case, some sperm might be found in the ejaculate and not leading to a spontaneous conception, but still usable for any RT. How should we urologists counsel a man in case of severe oligo-astheno-teratozoospermia or cryptozoospermia? Well, historically, the first answer to this question can be found in one study published more than a decade ago. In 2004, Greco et al. Was able to prove that the sperm defragmentation ratio is lower in testicular retrieved sperms than in those obtained by spontaneous ejaculation. These by TESE obtained sperms also achieve better results in the RT with a pregnancy rate over 44% compared to the 6%. Regardless the low number of investigated infertile men, the group of Kirk could confirm the higher rate of sperm defragmentation compared to the testicular sperms. In the following, I would like to refer to an excellent study by Esteves, who in 2017 examined this question and showed data about the fertilization rate, but also about the pregnancy rate. In his conclusion, he again confirmed this treatment concept, which urologists should keep in mind when counseling infertile men. Testicular sperm have lower level of sperm defragmentation than ejaculated sperms, whereby in case of high sperm defragmentation, the use of surgically retrieved testicular sperm for ICSI is improving the reproductive outcome compared to ejaculated ICSIs. Regardless, the authors around Zini argued in 2020 that there is no significant difference in live birth rates among the two groups, investigated a total of 187 couples. Again, Estevesandra, reanalyzing the same data, concluded oppositely that the pregnancy rate resulted remarkably higher after testicular ICSI compared to that one with ejaculated ICSIs. So in summary, European Association of Urology in 21 guidelines recommended approaching this practice with some cautions. They stated should only be used when other possible causes of SDF have been excluded. The AOA RSRM in 2020 noted the controversial nature of this practice and limited evidence, but that in a patient with high sperm fragmentation, a clinician may consider using surgically obtained sperm in addition to ICSI. And as stated, the European Academy of Andrology in 2018 recommends that in case of over 2 ICSI failures using ejaculated sperm with uncorrectable elevated SDF, couples can be offered the option of using testicular sperm for ICSI. So in conclusion, we believe in the case of OAT patients with uncorrectable high SDF and in case of cryptozoospermia, we agree with the AAA guideline statement. But when a woman is around 30 years old, we suggest the couple undergo a fresh TESE ICSI cycle after only one ICSI cycle failure if the previous oocyte recovery was favorable. And in case of cryptozoospermia with no found motor sperm, or in case of virtuous cryptozoospermia, we suggest performing a sperm retrieval by TESE and, if successful, performing a fresh sperm ICSI. Thank you for your attention. It was a great pleasure for me.
First of all, I would like to thank the organizing committee for inviting me to give this lecture. So over the years, we know that a number of reports have shown an association between sperm quality and ICSI outcome. And depending on the sperm source, whether ejaculated or testicular, there were some factors that could positively influence the outcome, such as surface proteins and maturation or epigenetic remodeling for ejaculated sperm, or reduced sperm DNA for testicular sperm. If we look into this sperm DNA fragmentation, we see that the DNA fragmentation is lower in testicular sperm. and that these rates are consistently lower, whatever the technique used for tunnel, for sperm chromatin decondensation. And after this meta-analysis, this was also confirmed in later studies with the COMET assay. A survey followed these observations from experts from 19 countries and showed that when there is an abnormal SDF, the decision to utilize testicular sperm instead of ejaculated sperm is affected in 67% of the responders. And so the hypotheses that underlie the belief that testicular sperm could be of better quality are first that DNA damage in ejaculated sperm begins after sperm has been released from Sertoli cells, that DNA could be less protected during epididymal transit if, like infertile patients, sperm can have decreased nuclear compaction. So this is about higher levels of residual histones and lower levels of disulfide bond formation. And third, that the post-testicular environment may induce sperm damage. If we now look into the clinical pregnancy rates in selected population with high SDF, you have here two populations, oligo-astheno-teratozoospermic patients without previous ICSI failure and non-azoospermic patients with repeated ICSI failure. And you see that in both cases, pregnancy rates appear to be higher for testicular sperm. This was data from the meta-analysis of TESE in 2017. And later there were a number of other studies that analyzed that question in a selected population with high SDF. And this study used the SCSA assay with DFIs above 30%. And you can see here also that the pregnancy rates were higher for testicular sperm. But there was some selection bias because the assignment to one or the other group was only based on the patient's preference, and the authors were not able to assess the DFI in the testis sperm because their method is based on cytoflowmetry, which requires higher numbers of sperm. Again, here in a selected population with high SDF, this time with the SCD, sperm decondensation test, we see that in a population where ICSI was first performed with ejaculated sperm, and then the patients were their own control. If it failed, they used the testicular sperm for ICSI. It's a very small series, but again, we see that clinical pregnancy rates were higher for testicular sperm. And again, here, there was no determination of the sperm DNA fragmentation on testicular sperm. Pregnancy rates were also evaluated between testicular sperm and ejaculated sperm in some other populations, like here in cryptozoospermic patients. So these are assumed to have high SDF. And as you can see, here again, we have higher pregnancy rates for testicular sperm. But the design of some of the studies that were included is questionable. For instance, in the Benami and in the Hauser study, fresh and frozen sperm were used with an unknown distribution between the groups. And for instance, in the study of Ketapchi, they compared ejaculated sperm versus surgically retrieved sperm from epididymal origin or testicular origin. Another population where this question was assessed were patients with necrozoospermia, meaning a vitality in the ejaculated sperm between 5% and 45%. It was a retrospective study. Here again, you can see that the pregnancy rates were higher for TESE ICSI compared to ejaculated ICSI. And what is worth to mention in this study is that if you compare two groups where female were younger than 35 years of age or older than 35 years of age, we see that TESE-ICSI was only superior in the group of the older patients. And this difference can be explained probably because in younger patients, the oocyte, the egg, has a capacity to repair this DNA fragmentation. Another population that was studied to respond to this question was the AZFC microdeletion patients. And here, as you can see, there was no significant difference between the use of testicular sperm and ejaculated sperm in terms of clinical pregnancy rates. But here, of course, this population is not assumed to have high sperm DNA fragmentation, and it are distinct populations that are compared, so probably not exactly the same patients. Finally, we have the last population where the question was analyzed, which are patients with recurrent ICSI failure. So it were patients with more than 2 failed ICSI cycles, idiopathic infertility, with SDF that was assessed by tunnel and SCSA, but before the oocyte collection day. And if you look then at the pregnancy rates of these cycles, you see that it was only in the group with OAT patients that pregnancy rates were higher with testicular sperm compared to ejaculated sperm. What was a little bit unexpected in this study is that if you look at the evaluation of tunnel and SCSA percentages, you see in the total, the right column, that the DNA fragmentation was higher in the testicular sperm, which is a little bit like unexpected. So this is why the authors also tried to subdivide their subgroup based on the tunnel assay with a threshold that is the recommended one above 36 to assess that it's high DNA fragmentation. And they found that in that group, there were higher pregnancy rates with the testicular ICSI. So as a conclusion, we can say that there is low quality evidence for higher pregnancy rate with testicular ICSI in the presence of high SDF. And this is because it was mainly small cohort studies, and we can understand that there would be ethical concerns to perform RCTs in this context because you have to perform a testicular biopsy while you have ejaculated sperm available, and this is important for the risk-benefit balance. There were also a lot of bias, mainly due to the design of the studies. For instance, they analyzed TESE after failed attempts with ejaculated sperm in the same patients. And of course, in this case, after a failed cycle, the outcome can only be better in a repeated cycle with ejaculated sperm or with testicular sperm. And then there were also cohorts of different patients who were assigned only based on the patient's preferences. There were a lot of confounders, so many of the studies did not control for female factors for paternal age, which was shown to be responsible of higher SDF with increased paternal age, and also the etiology of infertility was not controlled. There are also weak to no data to support the use of TESE-ICSI after prior ICSI failures in the absence of DNA damage. And finally, the data is not informative to perform a proper risk-benefit balance because there are many unknowns besides what we know is the complication of a testicular biopsy, but the unknowns are on the genetic and epigenetic risks where some studies are controversial, for instance, for higher aneuploidy in testicular sperm. We have to take into account the burden of childlessness and then on the other side, the uncertain impact on an improved ART outcome. So we could say that we can reasonably consider TESE-ICSI in men with high post-testicular SDF using a validated assay, provided efforts to reduce SDF in ejaculates have failed. It is also important that we identify the best candidates for TESE-ICSI, and for this we await more investigations on some preliminary pilot studies with other markers, such as the mNRNI protamine 1, protamine 2 ratio, which seems to be promising. So, and with this, I'd like to thank you for your attention.
Hello everyone. First of all, I want to thank the Global Andrology Forum for inviting me to this webinar, in which I'm going to talk about TESE for non-azoospermic men, embryologist perspective from the IVF lab. Testicular sperm obstruction, or TESE, is indicated for patients with elevated sperm DNA fragmentation. It has been reported that in the seminiferous tubules, the sperm DNA fragmentation is low, although it increases during the testicular transit, which leads to a difference between the testicular and testicular and ejaculated sperm in terms of maturity of the chromatin, DNA integrity, and RNA content. Other indications for TESE are severe oligo-astheno-teratozoospermia and cryptozoospermia, with a moderate level of evidence and a grade of recommendation from B to C. Just as in the traditional TESE for aspermic patients, in this kind of procedures, the handling of the sperm in the IVF lab is critical. First, we need to remove the testicular tissue as well as the blood cells and select the viable sperm for ICSI. But what is even more important is to control the air quality, the temperature, the pH, the centrifugation, and the sterile techniques to have the best ICSI outcomes. There have been several studies on the effect of testicular and ejaculated sperm in men with severe oligo-astheno-teratozoospermia or cryptozoospermia. This systematic review summarizes several studies such as Benjamin that found a significant difference between the testicular sperm and ejaculated sperm in terms of clinical pregnancy rate and live rate, with an increase with the testicular sperm. This trend was also shown in the studies by Bedkinson and Hauser, although they were not significant. However, in this kind of studies, the increase of the number of patients is required. In another systematic review by Aboaga, it was described that Pabuco in 2016 found that the fertilization rate was not different between the testicular and ejaculated sperm, although the abortion rate was significantly higher for the testicular sperm group. This was similar to what was found by Esteves for patients with high sperm DNA fragmentation plus oligoaspermia. It is remarkable the lack of information on the long-term and epigenetic effects of the sperm obtained by the testicle for the newborn. For patients with elevated sperm DNA fragmentation, the European Association of Urology summarized several studies which compare the ejaculated versus testicular sperm with similar outcomes in terms of higher pregnancy and labor rates using testicular sperm for ICSI, although the European Association of Urology made very clear that these studies have several limitations, such as they have a lack of comparison between the SDF of testicular and ejaculated sperm, as well as they have a very low patient number. This is the reason they made several recommendations for the use of TESE in men with elevated sperm DNA fragmentation. Some of these recommendations were that they don't currently advocate the routine clinical use of testicular sperm in non-azoospermic men with elevated SDF outside of clinical trials. However, this could be recommended by urologists to the patient by using informed consent. Another recommendation is to use testicular sperm only for this setting once the common causes of oxidative stress have been excluded, such as varicocele, lifestyle and dietary factors, or accessory gland infections. On the other hand, there have been some studies on the morphokinetics of the embryos created using testicular sperm. For example, in this study, we can see that there was a significantly higher number of direct unequal cleavage embryos for the patients that use testicular sperm compared to the ones that use ejaculated sperm. This is similar for the labor rate, where we found a lower rate for the embryos that had a direct unequal cleavage. As we can see in the panel on the left, the normal cleavage pattern for a zygote is from 1 cell to 2 cells, but for direct unequal cleavage embryos, they jump from the 1 cell stage to 3 cells in just one step. The reduced implantation rate of direct unequal cleavage embryos might be explained by a difference in the cytoplasm composition distribution. This can lead to biological consequences, since the cell fate decisions from the 8-cell stage can be influenced by molecules inherited from previous divisions. What I want to summarize for the take-home messages is that high-quality randomized controlled trials are required to determine the efficacy of TESE in non-azoospermic men. Also, that TESE for non-azoospermic men can be recommended once other infertility factors are discarded. And finally, that epigenetic and long-term studies need to be developed to know the effects on the newborn. Thank you very much.
Thank you very much for the presentation of Professor Pinguera, Professor Wins, and Dr. Ramirez for the excellent presentation. They present very interesting topic in andrology field, TESE for non-azoospermic men from 3 perspectives: andrologist, ERT specialist, and embryologist. Okay, without further ado, I would like to invite the panel member to present the question or comments. I would like to invite Professor Jody to give the comment or question. Please, Professor.
Thank you. Thank you so much. I really appreciate the presentations. Well thought out. A great work. My first question to Dr. Ramirez is related to the direct unequal cleavage at early stage of embryo development is related more to mid-piece and tail issues or problems rather than sperm chromatin issues. So relation to sperm chromatin damage needs further explanation. My second question to Professor Wayne regarding the testicular sperm. Testicular sperm may have increased prevalence of aneuploidy. So what is the expected risk? And do we need to consider PGTA, for example, FISH or NGS, before embryo transfer? Thank you so much.
Thank you, Professor Jody. I would like to invite Dr. Tan Phi Ly from Vietnam. Please, Dr. Lee.
Hi everyone, I'm Dr. Tin Lee. I'm from Vietnam. I have three questions for the presentational three speaker. The first one is to Dr. Liliana. So is there any cutoff value for the DFI for the testicular sperm in this replication yet? And the second one is for Professor Wynn. So what is the proposed plan for the case of retrodospermia? And the last one for Professor Pingera. So is there any role of hypogonadism treatment or varicocele repair before TESE in NOA patients? Thank you.
Thank you, Dr. Tan Lee. Now I would like to invite Dr. Cesar Rojas Cruz from Germany. Please, Dr. Cruz.
Thank you very much for the invitation. I will like to ask to all the speakers, taking account of the heterogeneity of the published results for this specific group of patients, obviously excluding all of the patients that are will not most highlight the data, the function of the ICSI. Do you believe that there is a role for TESE in this population outside a prospective clinical trial? Thanks.
Thank you, Dr. Cruz. Now I would like to invite Dr. Seso Sulijaya from Indonesia.
Okay, thank you, Prof. Ponco Birowo, for the opportunity, and thank you for great presentation for our speaker. Greeting from Indonesia. I have three questions for each speaker. The first one to Prof. Wins. Is there any cutoff for the FI, in which case TESE for non-azoospermic patient can be considered? And the second one for Dr. Ramirez. How could we select the testicular sperm with lower DNA fragmentation? Do you have any specific technique during ICSI? And the third one to Prof. Pingera. Is there any role of hormonal optimization such as FSH treatment before TESE? Thank you very much.
Thank you, Dr. Sulijaya. Now I would like to invite Dr. Cinta Abutari from Indonesia. Please.
Okay, thank you, Professor Ponco Birowo. Thank you for your excellent presentation, Dr. Wins, Dr. Liana, Dr. Pinjera. My question to Dr. Liliana Ramirez. If there is a cutoff value of DFI in ejaculated sperm already greater than 30% is classified as poor DNA quality, is there any cutoff value of DFI for testicular sperm yet? Thank you very much.
Thank you, Dr. Abutari. Now I would like to invite Dr. Maruto Harjangi. I think there is a technical problem. Now I would like to invite Dr. Sydney Glina from Brazil. Please, Dr. Glina.
Oh, hello, everybody.
Sorry, I cannot hear the voice of Dr. Glina. Sorry, I think there is a technical problem also. Now I would like to invite Dr. Guadalupe Hernandez Herbert from Mexico. Please, Dr. Herbert.
Hello, thank you for the excellent presentations. I have two questions to Dr. Ramirez. First, in the comparative studies of patients with increased SDF, was correction of common causes of oxidative stress performed? And second, what are the implications or potential implication of there being a higher percentage of embryos with direct unequal cleavage in the embryos made with TESE sample versus those made with sperm obtained by ejaculation? Thank you very much.
Thank you, Dr. Herbert. Now I would like to invite the famous doctor from Indonesia, Dr. Missy Safira, please.
Thank you, Professor Ponch, for the opportunity. So this is my comment for Professor Pinguera. So I should highlight that the TESE is not a panacea for all NOA cases. We should first address the treatable causes such as varicocele to avoid any unnecessary surgical sperm procedure, this is maybe like more cost effective, especially for couple who desire more children. And however, if there is no improvement, we can proceed to TESE, and that should be the choice, just like those with uncorrectable NOA or OAD with uncorrectable SDF. Moreover, this is can be justified with the Firza et al. In 2020 that say that sperm defect severity rather than the sperm source is associated with the lower fertilization rates after ICSI. Thank you.
Thank you, Dr. Safira. Now I would like to invite Professor Sofikitis, please, from Greece.
Thank you very much for the invitation. Actually, my contribution would not refer to a question, would refer to a general comment of a great clinical significance. Prior to the performance of TESE or micro-TESE, if there are any predictive parameters with high sensitivity, specificity, positive and negative predictive value. So we don't believe in the prediction of FSH. We reject the prediction of LH. We reject the prediction of testosterone. Hematoxylineosin has a limited value for prediction. So my comment would go to if there are some molecular biology parameters that would help the expert to predict if the male partner of the couple would be positive for testicular sperm or no. Looking through previous efforts in human reproduction, in andrology, in fertility, sterility, telomerase activity appears to have a predictive role, and the comment and the position of the European Association of Urology now is to go forward to evaluate molecular biology parameters for the prediction of the outcome of TESE rather than hormonal parameters. Thank you very much.
Yeah, thank you very much, Professor Sofikitis. Now I would like to invite Dr. Subhadev Chonduri from India. There is some technical problem. Now I would like to invite Dr. Sunil Jindal from India, please.
Yeah, thank you. First of all, thank you very much for the lovely program which has been here. And I have three clinical questions: that how long was the treatment given in terms of antioxidants, varicocele, surgery, lifestyle changes, pre-procedure? Is there a need to consider this both in ejaculated and testicular sperm? The second question is, do you give your patients antioxidants before a TESE? And has the DNA fragmentation been calculated pre and post treatment? The third is a comment of anybody on the DNA fragmentation versus the aneuploidy which is there, which is higher in the testicular sperm. And my personal feeling is, after having had a long experience with TESE, that to subject the patient to an invasive procedure needs to be looked into as the evidence needs to crystallize even further at the moment. Thank you very much.
Thank you, Dr. Sunil Jindal, for that question. Now I would like to invite Dr. Sonali Verma from India. Please, Dr. Verma. No, sorry, I cannot hear Dr. Sonal. I would like to invite Dr. Ioannis Tokolakis from Greece, please.
Thank you for the invitation. I would like to congratulate all the speakers for these wonderful speeches on the topic. A common question to all of them, I would like to ask if their opinion and if they believe that a micro-TESE is necessary for non-azoospermic men or the conventional TESE is enough, especially if you have the biologist in the operation room. Thank you.
Thank you, Professor Sokolakis. Now I would like to invite Dr. Rizwan Malik from USA.
Thank you so much. I'd like to congratulate on a great presentation. One of the things I'd like to highlight is the recommendations that have been made in terms of when to proceed with an invasive procedure like testicular sampling and use of testicular sperm. The issue remains a lack of consistent platform to assess the DNA fragmentation of the sperms and availability of such technology in different countries, such as developing countries. A whole lot of our participants are participating from countries that are developing countries where a lot of more expensive tunnel assays or other ways to analyze sperm DNA fragmentations may not be available on a broader basis. The other is the use of the antioxidants to see what antioxidants are used and to see their effect, and kind of there's no uniform consistency of antioxidant use and kind of their effect. And third is implantation failure. We talk about that in terms of their contribution and of the sperm, and at what level do we define the IVF failure? Is it at the fertilization level, at the rest post day 3, or at the implantation level? So I would like to see that those things addressed, to see kind of how do we make some consistent definitions, some consistent platforms where we need to address these things, and kind of more in developing countries from their perspective to see how does this data apply to those programs that are practicing in the countries, to see what kind of policy or what kind of practice that they can proceed in their with limited resources that may be available to them for sperm DNA fragmentation, because literature has borne out that just doing without DNA fragmentation studies in some of these situations, just moving towards sperm, testicular sperm, does not pan out good results either. So I'd like panel to discuss this aspect and some strategies based upon the literature that is presented as to what strategies can be utilized in those countries and those situations where the resources are limited, and we are trying to make the best for these patients, such as with OAT or cryptozoospermia, or failure at 38 weeks with cryptozoospermia with limited sperm availability.
Okay,
Thank you.
Thank you, Dr. Malik. Now I would like to invite, last but not least, Dr. Natmin Nguyen from Vietnam, please.
Thank you, Professor Pirogo. Thank you, all speaker, for great presentation. My question to Professor Pingeras, in compare the TESE, how about the outcome of the TESE, and which one is better in a man with OAT euspermia and cryptozoospermia? Thank you.
Okay, thank you, Dr. Nguyen. Now I would like to invite Dr. Pinguera to reply to the comment or question. Please, Dr. Pinguera, Professor Pinguera. I hope I pronounced your name right, eh?
I'm Dr. Pinguera from Austria. Thanks a lot. So thanks for the question for the panelists of Group 2 regarding my talk. There were really some excellent questions, which I would like to summarize and answer and trying to bring it a little bit more clarity to this very controversial topic, insofar as this patient group addressed herein is not the so-called classical azoospermic ones. But again, we must keep in mind that the expressed wishes of the infertile couple and appreciate the desire to have a child. That's the key point. Providing that that is the case, I believe, and now I'm addressing the question from Dr. Cesar Roya Cruz, that it's correct nowadays to at least to offer a TESE procedure, especially in case of increased DFI or ROS activity, irrespective of the heterogeneity of the published result for TESE in such population. In the recent published study in the August issue of the Journal of Assisted Reproductive Genetics, really the last one, Irene Herrera concluded that switching to testicular sperm for ICSI yielded better quality blastocytes without affecting the chromosome load of the embryos in non-azoospermic couples with previous unsuccessful ICSI using ejaculated sperms. So this strategy might be thereof a good option for some couples seeking live birth and who do not want to use a donor sperm. Then Cesar Sulivaya from Indonesia asked me about any benefit for any additional hormone therapy such as FSH treatment before planning and performing a TESE for non-azoospermic patients with high DFI. Well, the data, study data here are not such robust to advise uniformly to support a general FSH treatment, particularly if the man has just a high FSH at the beginning. So we must consider that FSH treatment is somehow expensive and not covered by every health insurance, not in Austria, not in Germany. Apparently, the Italian policy is here somehow different and providing such treatment modality with good results in their publication. This strategy was recently, right now, just correctly presented in the previous statement by Professor Russo Giorgio. Then we're moving to the question from Mrs. Savira from Indonesia. Has correctly pointed out in their question that it was absolutely necessary to investigate and to do everything possible to improve sperm quality before any TESE is performed. Correctly. I can completely agree with this, and I had emphasized this in my lecture. If there will be uniformly better preoperative screening tools like epigenetic or telomerase measurements, as suggested by Dr. Nikolaos Sofikitis from Greece, would be definitely of a great value, but we have to have this data there before. And responding to the question from Ioannis Sokolakis from Greece, again from Greece, I would like to point out that micro-TESE seems superior compared to conventional or systematic TESE or testicular aspiration technique. Nevertheless, we urologists should always start with the lowest surgical risk. So in our department, we always initially make a small incision in the tunica and examine the tissue intraoperatively together with the reproductive biologist. There is really no point to prolonging the operation if someone usable sperms would be found. And the colleague Natnik and Gian asked about the difference to TESE and TESA. Well, in a prospective study published in May of this year in the European Urologists, this question was investigated in around 100 well-selected men with non-obstructive azoospermia. Colleague Fuglesang from Denmark compared two surgery techniques, the micro-dissection testicular sperm extraction on the one side and the testicular sperm aspiration on the other side. And interestingly, he found that the micro-TESE gave a higher sperm retrieval rate around 43% compared to only 22% in the multiple needle pass TESE. So even as the study addressed no patient and therefore not all comparable to the group.
I think that because of time concern, I think I would like to invite Professor Wins to give a reply to the comment or question.
Yes, can you hear me? Because I cannot. Yes, it's okay, perfect. Thank you for the invitation, and then I will try to answer the different questions. So the first question was from Professor Zodi. So about the fact that there could be some aneuploidy in testicular sperm. So this is already controversial because depending on the technique that has been used, you can have higher aneuploidy rates or less. But there is an interesting study from 2022 by Hervas and collaborators where they performed a PGTA. It was only 27 couples, but they analyzed over 300, close to 400 embryos, and they found a similar aneuploidy rate for ejaculated and testicular sperm. So this was already some good news. And they also saw that there were good quality blastocyst traits and fertilization rates that were higher for the testicular ICSI. And then there is another study that is a little bit older from Alderweight in 2014, where they checked the malformation rates and they compared ejaculated sperm with testicular sperm, and they saw that in both cases, the malformation rate was a little bit above 2% and not statistically different from the other one. So this is for the question on aneuploidy. Then we had Professor or Dr. Tan, who asked a proposed plan for cryptozoospermia. So indeed, this can be a question that is debatable, because if you consider that when you do a micro-TESE, you will be, of course, with a ICSI procedure, and we know that when you use ICSI, there is less impact of high SDF. That is the first point. So the second point is that for all these attempts to do surgery when you have sperm in the ejaculate, and this is valid for all the types and the etiologies of male infertility, you have to take into account also the female parameters, especially the age of the female, because we know that there is some repair capacity of the egg. When there is high DNA fragmentation, you have to discuss with the patient about the risk-benefit balance. And indeed, if you have patients that have a long way with ICSI failures, then you could consider first to use some antioxidant therapy before discussing the testicular biopsy. However, there is, to my opinion, a question that is never taken up, is that when you look at the latest meta-analysis who looked at the effect of antioxidants on the sperm DNA fragmentation, overall, they didn't see any correction of that sperm DNA fragmentation. So I think the whole question is very debatable. Then we come
thank you, Professor Ruiz. Because the time concern, I'm sorry for the time concern.
Yes.
I would like to move the next speaker. I'm sorry for the interruption, but I think we have to move to the next speaker.
No problem.
Okay, thank you. I would like to invite Dr. Ramirez to give comment or reply the question or comment. Please, Dr. Ramirez.
Thank you, Dr. Virogo. Thank you for inviting me to this webinar. I'm just going to try to summarize some of the questions that are related between them. So, sperm DNA fragmentation for testicular sperm is not currently used as a routine clinical evaluation. Therefore, the creation of a cutoff value that has been asked by the panelists for this kind of assessment is not available right now. In fact, I think that we first will have to evaluate the purpose of such cutoff value. Why? Well, because since SDF testing for ejaculated sperm has been established for determining fertility potential of patients, we already have several studies indicating 30% of SDF as cutoff value as predictor of lack of pregnancy. So the determination of this kind of measurement should be determined
for what we need to know. We need to do if it's correlated with the pregnancy rate or it is correlated with the fertilization rate in case of testicular sperm. Also, regarding this kind of questions, we cannot distinguish right now when we're performing an ICSI for fertilization. We cannot distinguish between the low and high sperm DNA fragmentation between such sperms that we are injecting. First, we need to assess sperm DNA fragmentation in the whole testicular sperm sample, and then evaluate if the fragmentation is lower, as the literature says, that is lower than in ejaculated sperm. Another question that we had is that if we still need to do micro TESE, if we already do TESE, if we have a biologist in the OR. I think it would be good to use micro TESE, but just for reduce the risk of complication for the patients on the number of attempts, not for increasing the outcomes of the fertilization or other clinical outcomes. Regarding to Dr. Sodi questions on the direct unequal cleavage embryos, unfortunately, this kind of study didn't assess the sperm DNA fragmentation on testicular sperm. They rather are evaluating the difference between ejaculated and testicular sperm, where they found out that testicular sperm caused more an increased number of direct unequal cleavage embryos, and also a lower live birth rate. They say that maybe the higher incidence of direct unequal cleavage embryos might be because of the insufficient number of centrioles that are mature and that enter to the oocytes. So this will be one of the explanations of the low clinical outcomes, which is also related with the question of the sperm morphology, which is more related to the sperm, to the direct unequal cleavage embryos. So I think I have to stop now because we're running out of time. Thank you very much.
Apologies for the time, because your boss will angry to me if we exceeding the time. So
Yeah,
I think this session covered the challenging topic. TESE non-azoospermic men from three perspectives: the andrologist by Professor Pinguera, the RT specialist by Professor Wins, and from embryologist perspective by Dr. Ramirez. Every male infertility need to comprehensively assess and investigate it. The discussion of TESE versus ejaculated sperm is a hot ball right now. Both of these sperm has differences in terms of RNA and DNA and sperm chromatin, which may impact clinical pregnancy rates. As a urologist, the role is not only during the surgery, but also before the surgery to achieve an optimum result, which includes a cellular marker such as SDF. The impact of SDF to fertility are shown in many journals. TESE has become an alternative for uncorrectable cause of SDF, with higher pregnancy rates for ICSI. On the other hand, there is no clinical differences in patients with azoospermic factor C microdeletion. TESE may be used in case of cryptozoospermia with no found motile sperm. In terms of recurrent ICSI failure, TESE seems to show benefit in OAT patients. However, most of these studies come from many cohorts with many co-founders. The use of TESE ICSI in the absence of NOA damage more data needed, especially for proporis and balancenesis. Now, without further ado, I think we can go to the next session. Varicocele repair in severe OIT less than 5 million per milliliter. Will chair by Professor Florence Poitras. Thank you.
Hello, I would like to thank the Global Andrology Forum for inviting me to speak today. And over the next 7 minutes, I will show you why it is beneficial to perform a varicocele repair in men with severe oligo-astheno-teratozoospermia. We'll start out by defining what severe oligo-astheno-teratozoospermia is and review the indications for varicocele repair. We will evaluate how repairing a varicocele can lead to an improvement in semen quality or an upgrade in semen quality, improve ART outcomes, and also improve testosterone, sperm DNA fragmentation, and seminal oxidative stress. The classic abnormality seen on a semen analysis from a varicocele is the Oates pattern or oligo-astheno-teratozoospermia. There's no consensus agreement on what exactly the cutoffs are for severe oligo-astheno-teratozoospermia, but in general, severe oligospermia is defined as a sperm concentration less than 5 million per ml. Asthenospermia is generally defined as motility less than 40%, and teratospermia is generally defined as morphology in the Kruger form of less than 4%. So we can, in general, say severe oligo-astheno-teratozoospermia refers to a sperm concentration of less than 5 million per ml with reduced motility and morphology. The main indications for varicocele repair are in a man who has infertility with a clinically palpable varicocele, abnormal semen parameters, and a normal or reversible female factor during evaluation of his partner. Other indications include adolescents who have testicular hypertrophy or in men that have chronic testicular pain associated with the varicocele. There are several benefits of a varicocele repair. Many studies have shown and have published on the improvement in semen analysis parameters after a varicocele repair. In fact, there is a recent meta-analysis from the Global Andrology Forum that has been accepted for publication that has evaluated over 1,400 patients who have undergone varicocele repair and compared them to 996 controls who did not have a varicocele repair. This is the largest meta-analysis on varicocele repair, and the uniqueness of this study is it included a control group who did not undergo a varicocele repair. And this study showed improved sperm concentration, total sperm count, sperm motility, and sperm morphology in the varicocele repair group. There was a recent Cochrane database systematic review which identified 48 studies and found an improvement in pregnancy after varicocele repair with a relative risk of 1.55. The study said with couples who had no or delayed treatment, there was about a 21% chance of pregnancy compared to a 22 to 48% chance of pregnancy after varicocele repair. Another meta-analysis in 2015 demonstrated that pregnancy rates after a microscopic subinguinal varicocele repair were around 42%, compared to 17% for the group that underwent no treatment. Couples with severe Oates may require ART as part of their treatment plan. But there is a significant cost difference between IUI and IVF ICSI. We use total motile sperm count to help determine candidacy for IUI versus IVF-ICSI. Thresholds of total motile sperm count vary for IUI. And in general, if someone has a total motile sperm count between 5 to 10 million, they have a reasonable chance of success with IUI. Simplasky and colleagues did a study looking at 373 men who underwent a varicocelectomy, of which 139 patients had a starting total motile sperm count less than 5 million. After varicocele repair, the total motile sperm count improved from a mean of 2.3 million almost up to 16 million. And after varicocele repair, almost 60% of couples no longer needed IVF-ICSI as part of their treatment plan. Again, we know that couples that have severe male factor infertility with severe OATS may need to use ART despite having a varicocele repair. However, by repairing the varicocele, this leads to not only an improvement in total motile sperm count, as we saw on the previous slide, but also an improvement in pregnancy rate and live birth rate. There's been 2 meta-analyses that have looked at this very question, and both of them have demonstrated an improvement in pregnancy rates and live birth rates with odds ratio of about 1.76 for pregnancy rate and 1.699 for live birth rate. There's also been an improvement in live birth rates with IUI after a varicocele repair with an odds ratio of 8.36, demonstrating a significant benefit in this patient population. The primary intent to repairing a varicocele may be fertility related, but varicocele repair can help improve a man's overall health by increasing testosterone. Generally, studies show an improvement that ranges between 60 to 100 nanograms per deciliter in subfertile men with a clinically palpable varicocele who undergo a varicocele repair. Varicocele repair is also associated with an improvement in sperm DNA fragmentation, and there's been 2 recent meta-analyses that have shown about a 6 to 7% improvement in sperm DNA fragmentation. And we know that elevated sperm DNA fragmentation is associated with poor pregnancy outcomes. Seminal oxidative stress can also have a big impact on fertility, sperm DNA fragmentation, as well as embryo development. And a varicocele repair is associated with improvement in sperm oxidative stress as well. So some points to take home. Varicocele repair leads to improvements in semen parameters and can upgrade semen quality for ART. Varicocele repair prior to ART improves pregnancy and live birth rates. Varicocele repair can also improve testosterone, sperm DNA fragmentation, and seminal oxidative stress. A varicocele repair should be performed for all men with severe oligo-astheno-teratozoospermia. Thank you, and I'd be happy to answer any questions.
Dear colleagues, it is my pleasure to be invited into this outstanding event. I am professor of endocrinology from Europe, from Lithuania, and also I am andrology consultant in IVF unit. My topic is why varicocele repair is not worthwhile in cases of severe oligo-astheno-teratozoospermia. We all know that varicocele and semen quality are closely related. This is data from large cross-sectional clinical study into which more than 7,000 healthy young men from 6 European countries, including Lithuania and our centers, were enrolled. And study demonstrated that men with varicocele have significantly more impaired semen quality if compared to the men without varicocele. But as clinicians, we mostly are dealing with infertile men, and in some of them we have severe damage of spermatogenesis, severe oligo-astheno-teratozoospermia, and the main treatment methods and most effective treatment methods is assisted reproductive techniques. There are a lot of evidences indicating that surgical repair of clinical varicocele improves semen parameters, decreases seminal oxidative stress, peritoneal fragmentation, and increases the chances of natural conception. But when we are approaching IVF, it is not clear whether performing varicocelectomy in men with varicocele will improve treatment outcomes. In any case, better semen parameters in ART candidates are always better for embryologists. And this study demonstrates that even if in men with severe damage of spermatogenesis, with severe OAT, can have improvement, this improvement. In the first line of the table, we can see candidates for IVF with less than 5 million of total motile sperm count, and almost half of them had better semen quality after varicocelectomy, becoming candidates for IUI or even for natural conception. What is interesting from this study is that some men who were candidates for IUI, the second line, or natural pregnancy, the third line in the table, they had worse semen quality after varicocelectomy. And it confirms that it is difficult to predict actually which patient will have an improvement in semen parameters compared to another. What about the main reproductive outcomes in IVF? We all expect a healthy child, and the family, the main wish of the family, of course, is to have a healthy child. So pregnancy rates and especially live birth rates are the most important outcomes. There are two meta-analyses published in 2016 analyzing these outcomes and these outcomes relation to varicocelectomy. In the first meta-analysis, 4 studies were analyzed for clinical pregnancy rate. The results from these studies are different, but after the analysis, better clinical pregnancy rate was identified in the group after varicocelectomy. The same is about live birth. There are 3 studies, and better live birth rate was in the group of men after varicocelectomy. The second meta-analysis was published also in year 2016, and the results are as following. Pregnancy rate in oligo-aspermia group was not significantly higher if compared to men without varicocelectomy than in the case of varicocele. And regarding live birth rates, significance was reached. Higher live birth rate was in men after varicocelectomy. But what do the guidelines say? ASRM guidelines suggest to consider surgical varicocelectomy in infertile men with palpable varicocele and abnormal semen parameters. But varicocelectomy is not recommended for non-palpable varicoceles, and it is not recommended in the cases of azoospermia because of absence of definite evidence supporting varicocele repair prior to ART. European Academy of Andrology guideline. Varicocele treatment in infertile couples with OAT with palpable varicocele can be discussed with a couple. This is a statement. And only monitoring for subclinical varicocele is suggested. Also, varicocele treatment is suggested for young males with progressive testicular failure and or seminal deterioration. What is experts' opinion on varicocele repair in patients with severe OAT? There are data from Consensus published this year and prepared by the group by the group of Professor Agarwal, and you can see that majority of experts recommend varicocele repair before considering IVF. It is more than 60%. But also the other factors are taken into the consideration: female's age, severity of varicocele, infertility, duration, male age, and others. And if we will go to the next question, how experts answer the question when varicocele repair is not advised, you can see that majority of the respondents, at least 42%, answer that they will not recommend varicocele repair when it is mild. And also the other factors are mentioned, they are taken into the consideration when making decision. Is FSH above normal, female age more than 35 years, small testes, male age more than 40, and sperm count less than 1 million per sperm concentration less than 1 million per milliliter. So I would like to answer the question, summarizing the data I presented, why varicocele repair is not worthwhile in cases of severe OAT. To my opinion, conclusions from recent meta-analysis are questionable. Low number of studies analyzed. The difference p-value in pregnancy rate and live birth rate are borderline, and all authors agree that more cases are needed to make the final conclusions. Regarding recent guidelines, they do not comment on whether varicocele repair prior to IVF will improve pregnancy rates or live birth rates. And we all know that it's difficult to predict which patient with OAT will benefit from this treatment. And last but not least, varicocele repair differs treatment with ART, which is the most effective method in cases of severe OAT, for at least 6 months. Finishing my presentation, I would like to thank you for your attention. On the Europe map, you can see Lithuania in brown color on the Baltic Sea side. And on the right is view to my own city, Kaunas.
Hello, everyone. My name is Christina Anagnostopoulou. I would like first of all to thank the organizing committee for inviting me to this program. My subject is whether lab outcomes improve after varicocele repair in men with severe oligo-astheno-teratozoospermia. Varicocele is a very common condition. Approximately 15 to 20% of adult males have this condition, and this percentage is even higher in males with primary or secondary infertility. According to the AUA and ASRM guidelines, in the case of clinical varicocele and severe oligo-astheno-teratozoospermia, varicocele repair before ART should be considered. On the contrary, in lower grades of varicocele or in clinical varicocele followed by non-obstructive azoospermia, there is no evidence up to now supporting repair before ART. Overall, studies results suggest that there is an improvement in semen parameters after varicocele repair. In case that there is a significant improvement in semen parameters, it may allow the use of IUI or IVF instead of ICSI, offering more options to the couple for treatment. In case that there only ICSI is performed before and after varicocele repair, success rates are improved according to several meta-analyses. However, we cannot ignore several studies suggesting that in case that there is only a slight increase in sperm count and motility, there is no impact in improving ICSI results. These researchers could not find a benefit for oligospermic men in case of varicocele repair. So how can we explain this contradiction? First of all, the group of varicocele patients has a high heterogeneity. So each one of these patients has different varicocele grade, different semen analysis. Even semen analysis may vary from time to time to the same person. So there is a need to identify the profile of the person that will benefit more from this procedure. Another reason is that there are many confounding factors when patients are following ART. So even if sperm count or sperm motility improves, this doesn't mean that it will be translated to better lab outcomes such as fertilization rate, embryo quality, or most importantly, pregnancy rate, because these lab outcomes depend also on the female factor. So again, there is a need to identify the primary cause of infertility, and oligospermic men will benefit more, but if there is a coexistent female factor, probably the lab outcomes will not improve. In case of teratozoospermia, there has been seen a reduction in sperm abnormalities after varicocele repair. Interestingly, the majority of the practitioners responding to a global survey would, in most cases, advise varicocele repair, although this is not advised by the ASRM guidelines. Sperm DNA fragmentation is also related to varicocele. The congestion blood results in higher concentrations of reactive oxygen species, and this in turn can result in DNA fragmentation. Several studies suggest that sperm DNA integrity of clinical varicocele is significantly improved following VR. And in addition, the European Association of Urology guidelines recommends varicocele repair because it may improve sperm DNA fragmentation and ART outcomes. As a conclusion, this is an additional examination that in combination with sperm parameters may be used to help us identify the patients that will benefit more from this procedure. According to the most recent Cochrane database systematic review, there have been seen spontaneous pregnancy and live birth rates after varicocele repair. And according to this meta-analysis, there is an increase in live birth rates for oligospermic men undergoing ART after varicocele repair. If we need to do a patient selection, the best prognosis will have the people who are of younger age with higher varicocele grade, mild to moderate oligo-astheno-teratozoospermia, normal testicular volume, and serum FSH. In case of a coexistent female factor of infertility, success rates after varicocele repair are less likely to improve. And the female age must be also taken into consideration, as results may improve only 6 months after varicocelectomy. In that case, valuable time may be lost just waiting for the procedure. To conclude, varicocele repair may improve basic semen parameters and sperm DNA fragmentation. It also may improve pregnancy and live birth rate outcomes in men with oligo-astheno-teratozoospermia before treatment. However, lab outcomes are less likely to improve if there is a need for IVF due to a female factor. And as there is no guarantee for the outcome improvement, detailed counseling with the patient is needed to analyze the risks and benefits of the procedure. Thank you very much for listening.
Good afternoon, everyone. I am Professor Florence Boitrel, panel leader of this third and last session dedicated to varicocele repair in severe oligo-astheno-teratozoospermia. So I will now introduce the panel members one by one, and they will ask their question after introducing themselves. So we can start our world tour with Indonesia. Dr. Adrian Japari from Indonesia, please.
Thank you, Professor. Good evening. I would like to bridge those opinions. VR as an option should be offered to the patient with severe OAT with clinical varicocele after initial exam, hormonal exam, and genetic exam has been done to rule out another cause of severe OAT. Worsening of the sperm quality happens sometimes. This risk and the importance of sperm cryopreservation prior to VR should be explained to the patients before VR. Thank you.
Thank you. Dr. Petronella Oranagi from Romania.
Hello, everyone. Great presentation. Thank you. My question is it necessary to do 1, 2, or more SDF test? Thank you.
Thanks a lot, Dr. Petronella. We will move with Dr. Asli Metin from Turkey.
Thank you, Professor. Thank you for the excellent presentations. My question about is SDF sperm DNA fragmentation. Experts recommend varicocele repair before IVF only if SDF is high. How to decide whether the SDF is high or low? And also, several papers notified different cutoff values for SDF. Is there a cutoff value for SDF while deciding the level of that before IVF between different laboratory or patients? Thank you.
Thanks a lot. We will have now Dr. Marlene Zamora from Mexico. You are on mute. You are muted.
Hi.
Okay, thanks.
Thank you. My experience is that we are in severe OAT may not improve pregnancy and birth rates, especially if the cause is not well studied and the surgical technique is not careful in the management of the microvasculature. My experience is in favor of antioxidants before IVF. My question 1, in semen with severe OAT measure the potential of oxide reduction in semen with equipment such as meiosis could replace SDF. Q2, is feasible to measure which antioxidants are necessary to supplement in patients with severe OAT and varicocele?
Thanks a lot. We will now move to the next slide, please, with Dr. Neha Singh from India. Next slide, please.
Thank you all, and thank you for giving me this opportunity. I would like to have 2 questions. I wanted to ask that how is the pregnancy rate related after the varicocele repair, and how is the testicular volume associated with the severity of the varicocele and its repair? Thank you.
Thank you. And we will ask the IT team for the next slide because we will welcome Dr. Kirti Singh from Barbados. Dr. Kirti Singh, thank you.
Thank you, Prof. Florence.
Hello, everybody from Barbados, West Indies. And my question is directed to Dr. Amarnath Rambatla. It is that post-operative hydrocele is recognized as one of the most common complications following open subinguinal varicocelectomy. Although microsurgical subinguinal varicocelectomy is the technique of choice by most surgeons, given its several benefits. But it can be a limitation in some settings where the microsurgical procedure is not available. So my question is there any technique which can be used additionally, or can something be done during the operative procedure while performing open subinguinal varicocelectomy where micro varicocelectomy is not possible? Thank you.
Thanks a lot, Dr. Kirti. And next slide, please. We will welcome Dr. Melissa Morales from Costa Rica. Dr. Melissa Morales, please. Okay, we will welcome, next slide, please. We will welcome Dr. Vaida Simavanisian from Lithuania. Sorry for my accent.
Okay, hello. I would like to thank for all speakers for the interesting talks. And my question is for Professor Birutė Zilaitienė. You provided evidences that varicocele repair in severe oligo-astheno-teratozoospermia does not influence assisted reproductive technology results very much. As embryologist, I rather often see couples with male infertility sent directly for IVF without andrologist consultation. So do you support such approach? Thank you.
Thanks a lot, Dr. Vaida. And we will now move to the next one, Dr. Francisco Lizarragua from Mexico, please.
Thank you for the excellent lectures. To Dr. Amarnath and Dr. Bayrut, severe OAT patient is a testicular failure patient. We cannot allow the risk of damaging lymphatic vessels or arterial vessels, which of course will cause more damage. Microsurgical inguinal or better subinguinal repair should be warranted. This patient should be referred to a well-trained microsurgical urologist, or if we don't have one, consider radiologic selective embolization. Very important is to start antioxidants as soon as possible and continue for the entire spermatogenic cycle, at least 4 to 6 months. Thank you so much.
Thanks a lot, Dr. Lizarragua, for your comments. And next slide, please. And next slide. With Dr. Fernando Solorzano from Mexico. Next slide, please.
Thank you for the invitation to debates in andrology. I also want to congratulate the speakers for the excellent presentations. As an fertility specialist, there is an important concern about varicocele repair and worsening of the seminal parameters. My question is, if there's any previous factors to take in account for this kind of result, maybe previous labs, the learning curve of the surgeon, or the type of varicocele reparation? Thank you so much.
Thanks a lot, Dr. Solorzano. We will ask Dr. Dinesh Sheriam from India, please.
Thank you, Professor Florence, for the invitation. My question to Dr. Amarnath Rambatla is, what is the current evidence for varicocele repair in isolated asthenospermia? Thank you so much.
Great question, thank you. And we will ask now for Professor Eitan El-Bardisi from Qatar.
So if an SDF so how do you deal with the dilemma of measuring the SDF in this patient population? Especially, it is really very hard using different techniques such as SSD or tunnel with patients with less than 5 million or less than severe oligospermia. How do you manage to test SDF in these kind of patients? Thank you.
Yes, absolutely. Thank you for your question. So now I will ask our three experts to answer. So please answer your questions. So Dr. Amarnath Rambatala, Professor Biruzzi-Latin, and Dr. Christina Agnastopoulou, please, it's your turn.
Thank you, Professor Boytrell. So I'll try to address some of the varicocele repair and complications of varicocele questions over the next couple of minutes. So we know that there's often going to be a significant improvement in semen analysis parameters after a varicocele repair, but it's more difficult to study pregnancy rates because there are various factors such as couples' fertility or partners' fertility status and other things that are hard to control for. But in general, after varicocele repair, pregnancy rates are generally around the 40 to 45% mark based on a variety of studies. In terms of testicular volume, this can be a proxy for testicular health and spermatogenesis. And since most testicular volume is dedicated towards sperm production, this is a good marker. And so we know that clinical varicoceles can lead to testicular hypertrophy, and studies have shown evidence of catch-up growth, especially in adolescents and young men after fixing varicoceles. In general, about 50 to 70% of young men will regain normal testicular growth after repairing a varicocele for testicular hypertrophy if they have a clinically palpable varicocele. There's three main studies that looked at isolated asthenospermia in the literature, and 2 out of these 3 studies have shown an improvement in total motile count and pregnancy rates. And we recently performed a survey from the Global Andrology Forum where experts that were surveyed, 63% of them would perform a varicocele repair in the setting of isolated asthenospermia, and an additional 22% would recommend it in certain select cases. In regards to postoperative hydrocele, these can be seen in about 5 to 15% cases of varicocele repair, depending on the technique used. And the microscopic subinguinal varicocele repair is the gold standard, but we can try to optimize outcomes when this is not the technique that's employed. And so the risk of hydrocele can be minimized. If there's no microscope available, one can try to use surgical loops. It's also important to try to minimize dissection through the fatty tissue planes of the spermatic cord and remain close to spermatic cord vessels. And it's important to spare the internal spermatic artery, as there's usually surrounded by small lymphatic channels. And other techniques that can be used, you can use dyes such as isosulfan blue dye to identify lymphatic channels. This is a well-documented dye that's been used for lymphatic dissections. And so this can also be utilized. In terms of recurrent varicoceles, they should be repaired if patients continue to be symptomatic or if there's problems with fertility. And for example, if there's been an improvement in semen analysis after a varicocele repair and now a decline in semen parameters after a varicocele recurrence, this is a main indication to perform a recurrent varicocele repair. I think I'm running out of time, so I'm happy to answer the rest of the questions by email or on the forum. I'll hand it back to you, Dr. Boytrell.
Okay, thanks a lot, Dr. Amarnath. Dear Professor Biruzzi-Latin, please. Can you answer some questions?
Yeah, thank you, Florence. Professor Florence, first of all, I would like to thank all participants for their attention and faculty members for their support and interest. A few reflections to the comments and questions of panel members. First of all, to Dr. Marlene Zamora, I completely agree that most probably there is not big benefit from varicocele repair in the cases of severe OAT. Maybe in selected cases, of course, it may be useful. And regarding measurement of antioxidant concentration in seminal plasma or blood serum, it would be a very logical approach, an important step to personalized medicine. And there are studies who are showing significant improvement in semen parameters when antioxidants are supplemented when their concentrations are low. But unfortunately, in our region, we do not perform these tests for infertile men, and there is doubt, of course, for cost effectiveness.
Recording
Maybe
stopped.
others have the other experience in this. Also, I agree with Dr. Francisco Lizarraga that it's very important to start antioxidants as soon as possible after varicocelectomy, especially, and to continue for 3-6 months. And this benefit is confirmed by one of recent systemic reviews. Unfortunately, pregnancy rate was not improved with antioxidants in this review, antioxidants and after varicocelectomy. And my comment on Dr. Vaida Simanavičienė question is, I should say that I think it is mandatory to send infertile patients with severe OAT or azoospermia to reproductive endocrinologist or andrologist, and full workup should be performed, hormonal analysis, maybe it is treatable course, genetic analysis, patient has right to know a cause of spermatogenesis impairment and possible risks for the offspring. And finally, testicular ultrasound should be done as infertile men are at higher risk for testicular cancer, and this can save life of young men. And with my experience in our small country, and I diagnose myself from 1 to 3 new cases every year. So thank you, Professor Florence.
Thanks a lot, Professor Birut. I agree with you on your answers. So now, to conclude, we are listening to you, Christina, Dr. Christina Aniastopoulou. You can end this question and answer session, please.
Hello, everyone. Thank you for all these interesting comments and questions. Concerning the first comment, I would like to answer that I agree. Varicocelectomy has certain risks. This is why surgery should be performed only if specific criteria are met. Secondly, it is a good suggestion, especially if IVF is planned, to do preventive preservation of semen sample prior to surgery to avoid the worst scenario of worsening of sperm quality after surgery. Many of the questions concern the selection of tests to measure sperm DNA fragmentation. A number of methodologies are currently available to assess DFI. It is true that the COMET and the tunnel test are direct methods of assessment, and that the COMET assay has the advantage to differentiate between single and double strand breaks, which have different biological significance. Particularly, double strand breaks are severe, and they can result in the production of chromosome aberrations. They have also been associated with unexplained recurrent miscarriage in couples without a female factor. However, there exist also indirect detection methods that can measure the total DNA fragmentation based on the denaturing capacity of sperm chromatin. First is the sperm chromatin structure assay. That is a precise and repeatable test with the advantage that it needs only a concentration of 1 to 2 million sperm per ml, so it can be used also for oligo-astheno-teratozoospermic patients. And secondly, the sperm chromatin dispersion test that is simple to do with commercially available kits, and it has been shown to provide comparable results as the other methods. I would recommend to do only one test if the results are straightforward and the laboratory or detection method is trusted. Otherwise, the test should be repeated or even combined with the measurement of oxidation reduction potential that can be assessed by myopsis, as many of the panelists suggested. Now the cutoff levels depend on the type of test that is done. So in case of the SCSA, DFI higher than 25% corresponds to poor fertility potential, while in case of SCD kits, a threshold between 20 to 27% indicates male fertility. Finally, for couples with 1 year of infertility, probably the age of the couple would be a determining factor to decide about whether to go directly to IVF or wait for varicocelectomy. So, especially in cases of advanced maternal age, valuable time may be lost and chances for pregnancy may decrease, waiting for the results to improve after surgery. In any case, the consultation from a reproductive urologist is required. Thank you very much.
Thank you very much, Dr. Christina. And thank you all for your question and your answers. I will do a brief summary of our session. So our three experts agree that varicocele repair of clinical varicocele improves sperm concentration, total sperm count, sperm motility in oligo-astheno-teratozoospermia patients. It also improves the chances of natural pregnancy or pregnancy after ART, and reduce the SDF on oxidative stress. So Dr. Amarnath reminds us that microsurgical technique is the gold standard. Professor Beirut reminds us that it is difficult to predict which patient will benefit from varicocele repair or not. And for Dr. Christina, it is possible to freeze sperm prior to varicocele repair, and this is done in several countries, I think. So thank you very much, all we will thank you, our three speakers, and thank you all our members or our panelists. Thank you very much for this session, and I will leave the floor to my co-leaders for a more global discussion. Congratulations to all. Thank you.
My name is Dr. Ashok Agrawal, and I will be finishing the program with a small conclusion. This is an introduction to the Global Andrology Forum. But before I begin that, I want to thank our previous colleagues who did a marvelous job with 3 teams. The first one led by Professor Taha Hamoda from Saudi Arabia, who did a great job in having the presentation by 3 very renowned speakers and a team of 16 panelists from all over the world. The second led by Professor Poncho, who did a fantastic job, and the last one, Professor Boytrell, who did a great job managing the time. So thank you to each and every one of you, and almost 60 speakers who are part of this grand program, which has never been done ever in the world. So we want to thank them, and let us just introduce what is Global Andrology Forum and why we are doing this, what we are. So the Global Andrology Forum was started about 2 years ago as an international online group, which is collaborating for andrological research, and was formalized as a Global Andrology Forum in December of last year. The group includes more than now about 540 participants from 75 countries and 6 continents. And the main common theme in all of them is their common interest in male reproductive and sexual health. And these include andrologists, urologists, uroandrologists, gynecologists, embryologists, reproductive endocrinologists, researchers, psychologists, all kinds of careers and specialization are represented here. Our mission statement is to conduct the highest quality research in the world that has never been done, including systematic review and meta-analysis on controversial topics in male infertility, and a variety of studies that you see here. We also are very much interested in writing state-of-the-art reviews. The studies conducted by our members integrate basic science and clinical practice. Thus, it tries to bring together both researchers and clinicians, which is the main divide. And we promote educational and research activities, including scientific meetings, just like the one we did today, tutorial online tests, comprehensive training in research methodology. And we also work to provide the best available research and clinical evidence to enhance evidence-based practice in male reproductive and sexual health care, where there is a big shortage, a big deficiency of high-quality research and high-quality evidence, while maintaining a global perspective view of healthcare availability and patient belief and preferences. Our vision statement is to create a global collaboration of clinicians and researchers to promote scientific excellence in the field of andrology. Our group aspires to reshape the future of andrology by bringing together the most passionate, talented, experienced, and hardworking researchers and clinicians from all over the world. Did we succeed in that? I believe we have. If you look at the last count that we have here, we have about 540 now candidates who have joined, and they come from 75 countries. So this is a huge number, not as much as today's participants, who are more than 100 countries from about 1,450 candidates. And this is our management team. We have senior advisors like Dr. Rupin Shah, Dr. Florence Boitrel, Dr. Ramadan Saleh, and Dr. Taha Hamoda. And then our guest advisor, including many of the specialists from different parts of the world, Dr. Dama, Dr. Ahmed, Dr. Rosella, Dr. Jimmy, Dr. Arafa, Dr. Fo, and Dr. Kim. Our research publications, we have already published about 20 articles in high impact peer-reviewed journal in the last 2 years. And we are planning to publish another 20 in anywhere between the next 2 weeks to the next 3 months. So there is a huge effort in terms of not only conducting research, but bring them together and complete them and publish. And we have a lot of presentations. So let me show you some of the highlights of our publication. This is an editorial that we published, which was invited. This is about our forum, the Global Andrology Forum, a worldwide innovative online initiative to bridge the gaps in research and clinical practice of male infertility and sexual health. And this is written by many of our advisors. And this was published last year. So you are more than welcome to go and look and read, actually published this year. Sorry about that. And you can download, and it tells everything about what we are doing. This is the first time a group like this where we have an actual article which is available online in PubMed. Next is articles here. This is one of the articles which was published recently, which is the Consensus and Diversity in the Management of Varicocele for Male Infertility, results of a global practice survey and comparison with guidelines and recommendation. You can see the number of authors here. We have almost 150 authors from all over the world who participated in these research. So this is one of the benefits of working with Global Andrology, that not only you conduct the research, which is of the highest quality, you learn about how to conduct research, whether you are a clinician, you have never set foot in a lab, but this is not a lab research, this is online research. We also have many other publications. If you can look at this, is the first first meta-analysis of the largest type of varicocele repair on semen parameters in infertile men, and this has been published. Then we have this systematic review and meta-analysis on the use of antioxidant on natural pregnancy and and semen parameters in infertile men. As you can see, it's a randomized controlled trial, a study of randomized control, and hundreds of researchers, clinicians are involved in these studies who have been given proper credit. This is another one on comprehensive analysis of global research on human varicocele, a cytometric approach. These are some other which talks about specific techniques in a diagnostic laboratory, semen analysis, optimizing laboratory procedures and test interpretation. And this is the last, going towards the end. This is our website called globalandrologyforum.com. You can go to that website, and actually the section below is a screenshot of this from my computer, and you will see the home. The more important part for many of you is how to become a member. So if you press on this tab, you will be able to see the forms that you need. It's an online form. It takes a few minutes for you to complete. It also has contact us, so you will know how to contact us if you need to. So I will encourage each and every one of you who are watching this program or who have registered for this program and may listen to it later on, please look at this, go to the website, find many areas of interest. And if you are interested, if you are passionate about andrology and you want to change things around the world, then please come to us. Please come and join us, and we'll train you. We'll provide you all the training that you require, and you will have the company of experts from 75 countries. And we hope that by next year, this number will grow to more than 100 countries. So towards the end, the benefit of attending the debates in andrology, these are some of the benefits that you have earned. And I hope after we finish this presentation that you will be able to do a post-webinar survey and earn a certificate of training. So please take the test. Make sure that you take the test at the end, which will start after a few minutes. At this time, this is the snapshot of the city where I live. This is Cleveland, Ohio, and you are more than welcome to come and visit at any time. So thank you very much. But before I finish, I would like to invite Dr. Rupin Shah, the senior advisor to our group, to say a few concluding words. Rupin, can you please come?
Thank you very much, Ashok, and very, very big thank you to all the speakers, group leader, panelists. They worked really hard. What you see today is a fairly smooth flow. We had a few hiccups, which will always happen, but a fairly smooth flow. And to achieve this requires a huge amount of collaboration, cooperation, training, interaction, and planning. And over the past few weeks, the members of this symposium today have put in a lot of effort, including planning the questions, putting them down on slides, interacting with the speakers, to try and create a scientific program that would address the clinical queries that burn within the heart of every clinician. So thank you, all the faculty members at every level. And of course, a very, very big thank you to the audience of more than 1,000 who have stayed with us through this 3-hour marathon. I hope that all of you will carry home some useful messages that will enhance the quality of your clinical care. And with this, big thank you and a big welcome to all of you to be part of this global andrology movement. Bye.
Thank you very much. Thank you, Rupin. I would like to ask our organizer, Dr. Israel Maldonado, to say some concluding remarks and also thank our sponsors and our IT team for such a phenomenal job. So, Dr. Israel, please conclude and end this meeting now.
Thank you very much, Dr. Agarwal, for giving us this opportunity to collaborate with the Global Andrology Forum. I would like to thank the audience for being here, attending this program. I would like to, for professors, I would like to applaud your great scientific apportations in and the knowledge you had in order to enrich this working group towards changing paradigms over men's reproductive health and management of male factor in infertility, which I truly believe that it has been sadly left behind for several years. I hope you all enjoyed this experience as much as we did. And thank you very much for the opportunity. Thank you for the Global Andrology Forum. Thank you to the audience, and also thank you to all the professors. Thanks all of the professors. Thank you very much.